So thank you everyone for joining us for the Lung Cancer Conclave. It gives me great pleasure to introduce our program director, who's none other than Dr. T. Raja. He's the Director of Medical Oncology and also the Apollo Cancer Center, Chennai. I would also like to introduce our keynote speaker today, who's Dr. Mark Vincent. He's the professor of at the Department of Oncology at the Coolidge School of Medicine and Dentistry at the Western University of Western Ontario. Our chairpersons for the session are Dr. S. Subramanian, Chairman, Founder, and Senior Medical Oncologist at VS Hospitals, Chennai, and Dr. SVSS Prasad, who's a Senior Medical Oncologist at the Apollo Cancer Hospital, Hyderabad. So, without wasting any further time, I would hand over the mic to our program director, Dr. T. Raja. Over to you, sir.
Thank you, Kashish. And I once again welcome you all for this, academic feast ahead of us. And we have very exciting agenda. We are going to look at the length and breadth of lung cancer, and we're going to cover non-small cell lung cancer in the first half. And then we are also going to touch base on the small cell lung cancer. And we have a very, very, illustrious guest speaker in Professor Mark Vincent. And we're going to, first look at what do we do in early stage lung cancer and how immunotherapy has made a mark in early stage lung cancer. And then we will look at unresectable disease, and then for some time we'll spend our discussion on small cell lung cancer. So we're going to cover the entire gamut of what's happening hot in lung cancer. To begin the sessions, I'm inviting and I'm introducing one of the most academically sought out Professor Dr. Ashish Singh. He is the head of the Department of Christian Medical College, one of the pioneering teaching institute in southern India, Vellore. And Dr. Ashish will be speaking on the optimal mediastinal staging in early stage lung cancer. Dr. Ashish.
Very good evening. Thank you, Raja sir. Thank you for the invitation. And it's indeed an honor to be amongst all the gamut of stars who are going to gather today evening to discuss this interesting topic of lung cancer. Let me share my screen. So I was asked to talk about mediastinal staging, and that too optimal mediastinal staging in lung cancer. Kashish, confirm if you can see the slides.
Yes, sir. Your slides are visible, sir.
Yes. So optimal mediastinal staging in early lung cancer. So now we all know that this is an important aspect of decision making, especially when you deal with a patient who has a lung nodule discovered on imaging when he's symptomatic and he's come to you. Before I begin, a disclaimer: I'm a medical oncologist and by training, and I'm neither a radiologist nor an interventional pulmonologist nor a thoracic surgeon. However, while I was reading up for this talk, I mean, I must tell you that it was the thing that I would answer when we are optimal staging and what we actually, if you see, the lymphatic drainage of the lung was actually described way back in 1920s, and subsequently the surgical techniques were described, and surgeons described how do we do a lobectomy, how to do pneumonectomy, what lymph nodes you remove. It's only in the 1960s and 70s when CT scans came. Then as surgeons, as oncologists, we decided to kind of started to do pre-op imaging to define which patients are resectable and which are not. And the whole thing changed in the 1990s with the advent of PET. And as we all know, PET, in addition to giving you anatomical information, it also gives you metabolic information. And that actually opened up a Pandora's box on not only more information started coming, sometimes it started to become a headache because it started showing us a lot of things. And then there was this And then with this realization that as oncologists, when you treat patients who are actually locally advanced, by locally advanced, when I mean the diseases involving the lymph nodes, particularly in the midline group of lymph nodes, your outcomes were really poor with surgery alone. And therefore, you didn't want to do surgery alone for those patients. And so that's the importance of doing an optimal staging with whatever we have. And now we learn that the most important thing, what we are all looking for in a patient, is this unforeseen end to lymph node. What is unforeseen end to lymph node? Basically, what it means is that at the baseline, the treating surgeons or the oncologists felt that this is an early disease, and later in the course of treatment, you actually discover, no, I mean, that's mostly, it happens after surgery, and you discover, oh, this is an end-to disease, and sometimes you even describe the surgery as an unnecessary thoracotomy, because we know from, I mean, I know today we have a lot of speakers are going to talk after me, and we're going to look at the survival. We know the median survival of somebody who is having an N2, N3 disease is actually less than a year, and 5 years survival, we're talking about 30 to 40%, which is way inferior than many other stage 3 cancers we treat. Also, an optimal staging is required. Now we know that tumor size, if it's more than 3 centimeter, most of these tumors actually are aggressive and they do involve lymph node. And we definitely need to be very sure about what is the exact stage before we subject these patients to these expensive and morbid procedures. Also, it'll help you in ensuring which group of lymph node they should remove. Now lung cancer is a very, very different disease. Like, for example, cancer where you will run the lymph node without going to one. I mean, it does not. But lung cancer, it's not like that. I mean, you have various stations, and it doesn't follow a set pattern of spread. So if you remove certain stations and then you assume that patient is lymph node negative disease at surgery and do not offer him adjuvant therapy, that will be a disaster, right? If it's a false negative diagnosis you're making. So these are all the importances as an oncologist why you have to ensure that your mediastinal staging is accurate. Now, in terms of mediastinal staging, what we're trying to do is we're trying to make a very intelligent plan of how we go about confirming that this disease is indeed has not gone to N2 or N3 lymph node, and therefore my patient is a candidate for upfront surgery. Now, if you look at this diagram in front of you, which group of lymph nodes the disease is going to spread is it's very easy, obvious from this diagram is that it depends on where the tumor is located. If the tumor is located in the right side, those stations are different. In the left side, the stations are different. Even it's different if the tumor is medial or peripheral. So, and the most difficult of these tumors are the left upper lobe tumors. Now, what is the definition of N2 disease? Now, we know anything involving the mediastinal in midline is towards the side of the tumor at the midline is N2. So, like for example, subcarinal lymph node. Subcarinal lymph node will be N2 for the right side tumors, but then the midline line is actually drawn at the left paratracheal border. So, for a left side tumor, a subcarinal lymph node will actually be an M3 lymph node. Now, so and also we know that some of these lymph nodes are in close contact to the airway. However, some of these can be very far from airway, and therefore to reach them may be a challenge. Now I won't go into the staging. We are all aware of this. We also know that the staging subgroups, the stages keeps getting modified from AJCS 7 to 8 based on on how these patients are behaving. And what we have seen the change from 7 to 8 is that most of the 3As, most of the N2s now come under, the larger N2s come under stage 3B. And today evening, we're all going to discuss a lot about 3B. So just to keep in mind that we need to have a good staging assessment in the beginning. Now, what tools we have in the clinic when you see a patient with a shadow in the chest? So you can do imaging techniques. We have invasive but non-surgical techniques. When I say invasive non-surgical, I basically mean the scopes, either the bronchoscope or the endoscope. And then lastly, we have surgical techniques, predominantly mediastinoscopies. Now, the mediastinoscopy itself, there are various procedures. Now, the standard mediastinoscopy is a cervical mediastinoscopy. However, that's it has its limitations, and therefore to build on that, surgeons have discovered a lot of different video-assisted cervical endoscopic mediastinal lymphadenectomy, VATs, and different techniques. And each of these techniques have its own advantages, but also has its own morbidity. Now, before I get into the details, I just give you an outline on what we should be doing, what we do in our MDTs every day. So basically, you're trying to use an cross-sectional imaging in the beginning. That's usually a CT or a PET to kind of figure out that what is the chances that this patient is going to have an N2 or N3 node. So it's basically the pre-test probability, you may call, or the pre-testing chances that this patient may have. And we make that guess based on the location of the tumor, the size of the tumor, sometimes even histology, sometimes even SUV value, and also sometimes even the local stage, whether it's T3 or a T4, and so and so. So as you can see, for most patients, except that for a peripheral less than 3 centimeter, you have to ensure that your mediastinum is staged by endosonography. Now, endosonography, you can do either a EBUS TBNA or EUS-FNA. Why should you do both? You all know implement, because some cases where EBUS can reach, EBUS doesn't reach there. Now, if you have a patient where you strongly suspect this is N2, N3, however, your EBUS, EUS fails to confirm that, what do you do in such patient? Do you straight away go for surgery? The answer is no. Because even there, the probability of seeing an N2, N3 disease is almost as high as from different series is about 15 to 20%. And therefore, if you have a high suspicion, you have to do a surgical staging. Now, some of these things, as you see, the stars there has to be individualized, and it has to be discussed in the MA lymph node and other criteria. Now, what are the problems with doing CT or PET CT alone? Why do we need these interventional pulmonologists in the picture? Because we all go by CT scan. Radiologists will go by the size of the lymph node. Anything more than 1 centimeter is taken as positive disease, but it has a very poor sensitivity if you just look at size, only 55%. And also we know that from surgical series is that once these patients have surgery, almost 20% of lymph node positive disease were actually less than 1 centimeter on CT scan. Now, the problem with PET is it is very sensitive. Sensitivity is as high as 90%. But the problem is, even in the tumor, we know any SUV of more than 2.5 is positive, but there is no standard SUV in the lymph nodes, especially in our country where there can be a lot of granulomatous inflammation, tuberculosis, and other things, where an SUV of 3.5 or 4.5, what should be taken as positive? We don't have good data. And some clinicians actually also call these silly useless values, and especially in the mediastinum, where it's really difficult to interpret. And sometimes we even think, okay, should we have done this PET at all, or should we have just gone straight away for endoscopy and save money for the patient? Also, we know from the location that sometimes if it's lesion, even a central location tumor with negative mediastinum, the lymph node positivity can be as high as 20%. So that's the thing. Now, I will not spend too much time on this. So, as told you, size is important, and it's incidence of you having a occult N2 metastasis. For example, in this series, if the size was more than 6 centimeters, the incidence was almost as high as 57%. Now, let's come to talk a little bit about EBUS TBNA or EUS-FNA. Now, I told you both of these are complementary. Now, the reason why they're complementary is because you need the EUS-FNA mainly for the subcarinal and paraesophageal, the station 7 and station 8, 9. And all the other subcarinal, hilar, and paratracheal can be accessed with TBNA. Now, if you combine this EBUS TBNA, there's a meta-analysis of almost 2,700 patients. The median sensitivity goes up to 89%. The negative predictive value is 90%. And even the endoscopic one, the NPV is a little lower, 86%. So as you all see, the line stops at about 88, 90%. Now, earlier days when the station 5 lymph node was technically when it was positive, we used to call the thoracic surgeons or a mediastinoscopy. But now techniques have improved, the instruments have improved, and if you see on the right hand side, this is a station 5 lymph node which actually was sampled through an endoscopic EUS. So as I'm saying is that with our interventional pulmonologists getting better and better, they're able to sample almost all what you want, except for a few, through the trachea or the esophagus. Now, you do need the surgeons, especially if the lymph nodes are the aortopulmonary window or the esophageal lymph nodes. What do you ask the surgeon to do? Should the surgeon do a systematic lymph node dissection where you go one after the other, like you do, like you see in the EBUS, you go very systematically. You go first after N3 nodes, then N2 node, then N1 nodes, and all node which is more than 5 millimeters should be sampled, and you should not be only sampling what is positive on the PET or on the CT. Similarly, the surgeons can also do the same, but then it's cumbersome. It takes long time. Morbidity increases. So some people say, okay, systemic sampling or only lymph node sampling. If you see the recommendation, our International Association of Study of Lung Cancer will say that at least 6 lymph node stations should be removed, either during sampling or during surgery, for you to truly call this a mediastinum. This is some few pictures of thoracoscopy. This is on the right-hand side. Right-hand side is usually station 2, station 4, and station 10. And this is left-hand side. And even this requires a lot of dissection. The picture on the bottom is actually after the lymphadenectomy is complete for other station. So this is just a table which is looking at all the possible permutation combinations you can have: CT, PET, EBUS, mediastinoscopy combination. As you keep on adding, your reach becomes better, but your sensitivity also improves. However, the cost also goes up, so that's what we need to mind. Now, what about patients? Can the patients go for surgical staging alone without going through endosonography? There was a large randomized trial called ASTA, where they found that the sensitivity and specificity was more or less kind of similar. Here the gold standard was the surgical lymph node pathology report. But then if you went for endosonography, your unnecessary thoracotomies could be reduced by 7%. That means 7% of your patients are having unnecessary surgery. And by doing endosonography and not going for surgery, or rather going for CTRT, you don't compromise on your 5-year survival, which is about 35% in both arms. And patients here had reduced cost, obviously, because some of them didn't have surgery and they had better quality of life. We all know thoracotomies can give rise to so much of pain and morbidity in the post-op period. And also, there's another meta-analysis which showed that the probability of having a mediastinal metastatic disease after a negative endosonography is about 15%. So that is also, you have to keep in mind that no test here is more than 90% effective. And so I think I'm crossing my time. So with that, I will want to just wind up. Also, there is another study called SCORE study, which is looking at endosonography as compared to a systemic nodal sampling. And they found that this EBUS TBNA was more sensitive in detecting as compared to lymph nodes on the PET. So therefore, as I was saying earlier, if you have financial constraints, it makes more sense to go straight away for endosonography than do the PET CT, especially for central lesion. So we have treatment algorithm. One algorithm I had shown you earlier, and this is another similar algorithm, this is from this is a recent publication from one of the societies. Basically, what they're saying is, do not believe what PET is saying. You have to confirm it pathologically. And if your endosonography does not confirm it, you have to do it mediastinoscopy. Then only you please make a decision for surgery. And with that, I will want to stop here. And just last few words, all this is guidelines, all these are standards. But even in a country like the Netherlands, how much are these guidelines followed? And if you see, this was a large study, almost 5,000 patients. When they looked at their own data, they found that actually these guidelines are followed only in about 20 to 30% of patients in the clinic. So for most of the time, the physicians are actually not sticking on to guidelines. And your unforeseen N2, which we all fear and we don't want to happen, is in the range of about 15%, even in a country like the Netherlands. So thank you for your attention.
Thank you, Dr. Ashish. It was an excellent lecture on, you absolutely spoke like a pro surgeon, and you really told us how the versatile use of various modalities, right from the scans to the semi-invasive scopies and endosonographies, and then how to include the various invasive modalities. And you emphasized the most important aspect of how to be very, very diligent with your lymph nodes, lymph nodal stations, and how it can be prognostic for your patients, and how it can really determine the treatment options of your patients, how one needs to be exhaustive on elaborating the mediastinum. That was an excellent lecture. Thank you for that. We'll move on. We have Dr. Krishna Prasad with us. He's a senior consultant medical oncologist from Mangalore Institute of Oncology, Mangalore. And he's going to speak on updates in the management of early stage lung cancer, stage 1 to 3. So Dr. Krishna Prasad, please go ahead.
Thank you, sir. So basically my topic is systemic treatment in operable lung cancer. So the points for discussion today is Seton, ADAURA trial, failures and the future. So first, getting onto the Seton trial, it's an adjuvant trial where the final overall survival analysis was presented in ASCO last year. So basically it's a Chinese trial where they took patients with completely resected stage 2 and stage 3A non-small cell lung cancer with mutation of EGFR and randomized them between gefitinib for 2 years versus vinorelbine and cisplatin for 4 cycles. The primary disease-free survival, which was their primary endpoint, was already presented before, and it showed a significant difference in terms of disease-free survival improving from 18 months to 28.7 months. So the current presentation was the final overall survival analysis. And you can see that in this final overall survival analysis, overall survival was slightly prolonged, but was not significantly improved compared to the chemotherapy arm. The hazard ratio being 0.92 in both the intent to treat arm and the per protocol analysis. So what about the updated 5-year disease-free survival analysis? There again, the benefit was there, but it seems to be decreasing compared to the 3-year disease-free survival analysis. You can see that the hazard ratio is still 0.5 and 6 and 0.51, but you can see over a period of time, the difference in the curves is reducing. What about patients who were offered tyrosine kinase inhibitor after completing or failure of this treatment? So you can see that post hoc analysis of overall survival with respect to the subsequent treatment shows clearly that subsequent TKI given either for the people who have received gefitinib or for the chemotherapy arm before shows significant benefit compared to getting some other kind of treatment. Also, another post hoc analysis showed that patients who received more than 1.5 years of gefitinib as adjuvant did significantly better compared to quite a few patients who received less than 18 months of treatment. So what did they conclude? They concluded that the significant disease-free improvement survival which was seen initially did not translate into overall survival benefit. However, prolonged overall survival was observed in those treated with adjuvant gefitinib for more than 18 months, and subsequent treatment with osimertinib was associated with a better improvement in survival in both the treatment arms, concluding that adjuvant therapy with the TKI should be a standard of care in patients with completely resected EGFR mutated early stage lung cancer. So what about the ADAURA trial? This was the landmark trial which was presented in a plenary session in ASCO 2020. So we all know the outcome in early stage non-small cell lung cancer needs to be improved. Otherwise, the 5-year recurrence rate generally is around 45% in stage 1B. It is 60 and 75% in stage 2 and stage 3. So this ADAURA trial, which is a phase 3 double-blinded study, randomized patients with this early stage lung cancer post-surgery to either osimertinib 80 milligram once daily or a placebo. Now, this trial actually was presented in a haste in ASCO 2020 following an independent data monitoring committee recommendation. This was the study was unblinded early and immediately presented. So this analysis was an unplanned interim analysis. So the characteristics are typical. This is the 2/3 trial where 2/3 of them are females. 2/3 you are into your age at 64 years. That is a median age. 2/3 are non-smokers, Asians, and with performance status 0. 50-50 of them got adjuvant chemotherapy and are exon 19 deletion and L858R, and 50-50 got MRI and CT scan. You can see that osimertinib improved the disease-free survival versus placebo in resected EGFR positive patients in both the primary population as well as in the overall population. How much did it reduce by? 83% reduction in the risk of disease recurrence or death with osimertinib in the primary population and 80% in the overall population. And every subgroup actually showed benefit with osimertinib. Now, this is a very early 5% of the patients where the overall survival has been presented, which shows 100% overall survival at 2 years compared to 93% with placebo. One of the important things is how do these patients actually recur? Because if you see osimertinib arm, 38% recurred locally, systemically, whereas 62% recurred locally, compared with patients who have received placebo, where a lot of patients had a distant recurrence. Why is it important? We know that the local recurrence is not that bad compared to distant recurrence. Also, the other recurrence which is of worry is the CNS recurrence, and we know in the metastatic disease, osimertinib is a good drug for that. And even in this ADAURA trial, out of 45 patients who had CNS DFS events, 33 of them were actually, 39 of them actually came up in the placebo arm, and only 6 of them came in the osimertinib arm. Osimertinib, as we all know, is very well tolerated, and the major side effects is diarrhea and skin changes. Grade 1 to 2 interstitial lung disease was found in a small percent, as well as QTc prolongation. Now, this trial was again presented in the World Lung Cancer Conference, where they saw whether the postoperative chemotherapy usage was any, made any difference to the matter. You can see that around 80% of stage 3 patients received adjuvant chemo, 70% in stage 2 and 25% in stage 1. And if you are less than 70 years and Asian, you are more likely to receive chemotherapy. And irrespective of whether the patient received adjuvant chemo or not, the DFS was significantly better. And the DFS was better not only in stage 3, also in stage 2 and stage 1, suggesting that a clinically meaningful DFS benefit is observed with or without chemotherapy, regardless of the stage of the disease. Another part of it was presented again in World Lung Cancer Conference, where they looked at patient-reported outcomes, and they saw that the health-related quality of life was excellent, both in terms of the physical as well as the mental status. So what is the conclusion of the ADAURA trial? In unplanned interim analysis, adjuvant osimertinib significantly prolongs the disease-free survival in patients with completely resected early stage lung cancer, seeing an 83% reduction in the risk of recurrence and death, 79% in the risk of reduction and death in the overall population. Disease-free survival is prolonged across all subgroups. There is a decreased risk of CNS recurrence, no adverse impact on the quality of life, suggesting it should be the standard of care. There are some interesting arguments against this trial. Not every patient was necessarily required to have baseline imaging. However, we also know that most of them got it done. Nearly 50% of them had CT brains. CT brain, we know, will miss around 10% of brain metastasis. So this complicates our ability to interpret these results to say whether osimertinib is actually treating subclinical CNS disease. Also, the big argument was making the disease-free survival as an endpoint, the primary one, is a gambler's dream, because we already know that you're going to win. Because we knew that gefitinib and erlotinib, which are much less effective and more toxic compared to osimertinib in metastatic disease already had shown DFS benefit. So what was the point in showing a DFS benefit which was already known? Maybe because DFS endpoint costs less money, and also it makes more money for the company because you can already release the drug for usage in the population. The extent of benefit of osimertinib over the first generation drugs should have been the question in ADAURA rather than against placebo. So the argument continues to say this is an early answer to an irrelevant question. Also, it has not shown definite improvement in the quality of life or the duration of life compared to those patients who will get osimertinib when they relapse. 45% of them did not receive adjuvant chemotherapy, which should have been the standard of care. So it is definitely of concern. Now, counter to this argument is patients have not been unblinded. Only the data has been unblinded. So you will get the overall survival benefit. But how long are you going to wait? Are you going to allow these patients to have, progression and just say that overall survival has not been seen? Because overall survival data will take time. So there is definitely benefit for osimertinib irrespective of whether chemotherapy has been delivered or not, and maybe waiting for overall survival may not be the right thing to do, because the 3-year disease-free survival with osimertinib is itself more than the 5-year overall survival in patients with early stage lung cancer. There are other trials which are going on in this setting. The Alchemist trial, where actually they are struggling in the US to enroll patients into this, especially when the ADAURA is out. How are you going to enroll patients to an inferior drug in this setting? Also, there is the Neo-ADAURA trial, which is going on, including in India. Some of the centers are participating, where you use osimertinib as a neoadjuvant therapy. So what about some negative trials? Attacker trial was basically looking at whether we can tailor the use of platinum as well as use of pemetrexate, because we know when ECCR expression is high, platinums don't work, and when the thymidylate synthetase expression is high, pemetrexate doesn't work. So when they try to tailor this, they found that there is no significant benefit, even though the toxicity seems to be better. So they suggested that there is no statistically significant trend for benefit in either relapse-free survival or overall survival for adjuvant treatment in tailoring trial. However, it improved the toxicity. Finally, what about immunotherapy? Based on the theoretical feasibility that neoantigens derived from a tumor are present, most of the clinical trials with the immunotherapy agents have been using it as neoadjuvant rather than adjuvant. This neoadjuvant atezolizumab trial for resectable non-small cell lung cancer, called the Princeps trial, used one single injection of atezolizumab before surgery, and they found that most of them had stable disease, whereas some people had pathological good response. Telling that it is safe, did not impair surgery, and a small percentage had a major pathological response. The other trial was the neoadjuvant Durva trial in resectable NSCLC, where they gave 3 doses of Durva before surgery. They showed the primary endpoint was complete resection, and most of them had a complete resection. Secondary endpoint was a partial response and a major pathological response, which was not very good as expected. It was pretty safe. However, this was stopped early because there was increased mortality in the 90-day postoperative setting. The argument is this mortality is not related to Durva, but this trial has been stopped. So we're seeing a similar trend in what we are seeing in the metastatic setting. Single agent immunotherapy has very little response, and I think we should combine it with chemotherapy. The Nadeem trial, however, when they assessed this combination, they found that higher toxicity is there, so maybe it will delay the surgery, which is the main treatment. This is an eagerly awaited study, the EGAN study, basically looking at perioperative Durva with preoperative chemotherapy, because I think the combination of chemo with immunotherapy is the way to go. So concluding, ADAURA is a practice-changing trial. There is no doubt about it. Tailoring chemotherapy according to the mutation has been unsuccessful. Neoadjuvant immunotherapy are large volume in clinical trials. Thank you.
Thank you, Dr. Krishna Prasad. An excellent lecture and an excellent overview on what's happening in the landscape of early stage lung cancer, stage 1 to 3. I think you adorably covered the ADORA trial and the Jefferson trial. And you also touched upon the various neoadjuvant tactics that are emerging, and some of them are promising, and also how people are working on tailoring the neoadjuvant approach or the adjuvant approach according to possible biomarker use and whether they are successful or not. So that was a very, very important lecture and a lot of food for thought for us. Thank you so much, Dr. Krishna Prasad. We'll move on to our next speaker, Dr. Vijay Reddy. He is my senior colleague in our own institute. He is the director of the Apollo Cancer Hospitals, but in another city, Hyderabad. And he's one of the pioneer and doyen of the radiation oncology. Today, he is going to deliberate on the optimal radiation delivery in stage 3 non-small cell lung cancer. Sir, Dr. Vijay Reddy.
All right, thank you, Dr. Raja, and thanks for the wonderful opportunity. I'm trying to share the slides. All right. Thank you, Dr. Raja. And I don't know what Dr. Raja meant to say, optimal RT in stage 3 non-small cell lung cancer. Whatever I could understand, I'm presenting that talk here. So optimal means when to do radiation in stage 3 lung cancer, what I understand, and what dose that need to be used, and does the new technology has helped us in this stage 3 lung cancer treatment delivery by radiation treatment. Next, how to move the slide. Okay. So timing of radiation therapy, as we had several trials, discussions, debates on whether to give chemotherapy alone or neoadjuvant chemo followed by radiation, or followed by radiation plus chemotherapy, or concurrent chemoradiation. So I'm going to show you some landmark trials. One is RTOG 9410. For 597 patients, we compared with sequential chemotherapy followed by radiation versus concurrent chemoradiation. So the median survival and the overall survival are much better in concurrent chemoradiation arm. 21% overall survival at 4 years versus 12%. It's almost double. Similarly, URTC trial showed the difference in 3-year survival from 22% with sequential chemo followed by radiation versus concurrent chemoradiation, which is 34%. Now, the Cochrane review of 14 randomized studies, 2,300 odd patients, where they have clearly shown that the concurrent chemoradiation had better locoregional progression-free survival and progression survival locally as well as any site. So concurrent chemoradiation was declared as a standard of care. And subsequent Cochrane analysis in 2010 added another 25 randomized studies, which included 3,000 odd patients. They compared concurrent chemoradiation versus sequential chemoradiation, sequential chemotherapy followed by RT plus CT. And they have shown that the overall survival was definitely superior in concurrent chemoradiation arm. Similarly, progression-free survival was much superior in all cases where they have shown clearly that progression survival was superior in concurrent chemotherapy arm. However, the toxicity was much, as expected, much higher in concurrent chemoradiation arm. So concurrent chemoradiation versus RT alone, there was clear absolute 8% benefit in survival at 2 years. Similarly, in sequential versus concurrent, there was 10% absolute survival benefit at 2 years with hazard ratio of 0.74. Now, as NCCN guidelines in 2021, either you think of doing a preoperative treatment before surgery, it has to be a concurrent chemoradiation in superior cell tumors or in T4 lesions as well. And even in stage 3A, anywhere, any site, if you're planning to do preoperative therapy, it has to be concurrent chemoradiation compared to chemotherapy alone. If it is unresectable, obviously it is concurrent chemoradiation therapy as a definitive treatment. Even in stage 3B inoperable or stage 3C inoperable, it has to be concurrent chemoradiation treatment as category 1 evidence. So if you look at all the tumors that we treat today, let it be head and neck, cervix, lung, or stomach, it is to be a concurrent chemoradiation, certainly not a sequential therapy or only radiation alone. Now, one more thing which I wanted to say or present is that in a stage 4 lung cancer with limited metastasis, after you give systemic chemotherapy, consolidation radiation to the primary would certainly improve the overall survival. This is 41.2 months versus 17 months in a patient who are left out after systemic chemotherapy. So this has become a standard of care now in a limited metastasis after systemic chemotherapy. So role of RT in carcinoma lung, if you focus on stage 3, preoperative CTRT for stage 3A, postoperative CTRT for selected patients where margins are positive or nodal positive disease, definitive therapy in inoperable stage 3 lung cancer, and obviously the last one which I would like to stress is a post-systemic treatment as a consolidation. You need to do the local radiation in stage 4 disease as well. What dose is optimal? Again, going back to the studies of RTOG, 2 studies, 7301 and 7302, clearly indicated 50 is better than 40 and 60 is better than 50 gray to the primary and to the mediastinal lymph nodes. Subsequently, they went on to add some more dose of radiation from 60 gray to 74 gray. This was in the era of 3-dimensional 3D CRT, and this trial was negative. Increasing the dose to 74 gray actually was detrimental. The results were inferior in 74 gray compared to 60 gray. This is as simple as saying this is because of the radiation-induced pneumonitis. Now 74 gray was no good over 60 gray. And subsequently, there are several trials trying to add stereotactic body radiation only to the primary after delivering 60 gray without increasing dose to the lung have shown better results. And the day is not too far where we going to go higher doses than 60 gray. Now SBRT increases, definitely you can increase without increasing the radiation pneumonitis. Now the standard dose is as of now is 60 gray in 30 fractions to the primary as well as to the lymph nodal areas. So why is that we are having problems with increasing the dose and radiation to the lung? This is as simple as that we need to confine our dose to the normal lung. That is what you call is volume of the lung getting 20 gray should be less than 35 gray. 35 to 40% of the lung should get less than 20 gray of the volume. So in patients who have got patients who are elderly or taxane patients who have received taxane-based chemotherapy, then the V20 has to be less than 35. So now coming to the technology in where we could reduce the dose to the normal lung, and how is that possible and how we are able to deliver these days. We know the technology has enormously substantially is increased in the recent past from 3D CRT to the IMRT and image guided radiation therapy. So coming to the volume delineation, the amount of lung which is radiated is significantly reduced by the new technology. One is PET CT scan, where we are able to define the tumor versus the collapsed lung. So definitely the volume of the lung which is radiated obviously reduces. So PET CT helps in reducing the volume of lung radiation. Now 4D CT is allowing us to take multiple pictures and give a proper volume delineation, and added to that we have today maximum intensity projection, where we see the lung movements and what kind of tumor, what is the movement, what is the 30 to 70% of the areas where we can target this lung volume so that we can reduce the normal lung radiation. So 4D CT and MIP has definitely decreased the volume of radiation to the normal lung. Internal target volume is reduced. Obviously, the normal lung radiation has definitely reduced in target volume delineation. Now coming to 3D CRT versus IMRT, there is a phenomenal change in the method that the treatment is delivered. If you look at the 3D CRT, this entire area gets radiation. Dose conformity around the target is much reduced with IMRT, and obviously that the volume of the lung getting 20 gray is significantly reduced with IMRT. Look at this pictures, you can easily identify that. So with the volumetric arc therapy or 3D IMRT, we're able to reduce the volume of normal lung reduced dose radiation from significant 35, less than 35% of the volume getting 20 gray. So similarly, but the volume of lung getting 5 gray is significantly more with IMRT and with volumetric arc therapy. However, that is not going to cause major problems to the patients. Now, if you look at this graph, you see the 3D CRT, the 20% of the 35% of the lung getting 20 gray is significantly higher with 3D CRT, with significantly low with volumetric arc therapy or IMRT. Now, other technique that we use today is a breath holding technique, where we ask the patient to hold the breath so that the tumor is not moving up and down. So significantly, advantage is relatively simple and efficient, and disadvantage is inconsistent pattern. But however, this is commonly practiced in majority of the centers where we can reduce the volume of normal lung being radiated. Now, the other technique is respiratory gating, which is available in most of the higher centers in the city, in various cities, where the beam is on only when the tumor is coming to the target area. So this is how the treatment is delivered. When the target comes to this area, then only the radiation beam gets opened up. So this is called respiratory gating. So if you look at that, with the advent of 4D CT and IMRT, we are able to reduce the grade 3 toxicity, that is radiation pneumonitis, and subsequently, obviously, that the overall survival would be better, and this is shown clearly in the graph here. Now, the proton, the big hype these days, you heard about the proton. The greatest advantage of the proton is there's no exit dose and reduced side effects. That is the most significant part of this proton beam therapy. So radiation pneumonitis is significantly less. So this is how the linear accelerators work, and this is how the proton works. There is no exit dose in the proton beam, so that 20% of the radiation that is given to the normal structures is reduced. So obviously, it is attractive for clinical use in the thorax, where the normal lung, heart, and esophagus, spinal cord would significantly get the reduced dose of radiation. So this is how you see the proton and the photon here. Reduced dose to the heart and lungs is graphically seen here. So reduced dose to the normal lung with the proton compared to the IMRT or volumetric arc therapy. So high-tech radiation therapy certainly reduces the volume of lung. Getting 20 gray would be much reduced by IMRT and image-guided radiotherapy and volumetric arc therapy, and moving target localization, 4D CT and MIP significantly reduced pulmonary toxicity. PET CT and 4D CT has reduced the RT target volume delineation because we can localize the target very easily and clearly. SRS SBRT has significantly changed the total scenario in the radiation field, where you can deliver high dose of radiation to the primary disease. Proton therapy definitely reduces the toxicity to the normal structures, and obviously dose escalation to the tumor is possible without causing a radiation pneumonitis. But you need to understand that we should also be very careful when you're treating when a patient with a COPD, or when a patient has got already lung damage and large volume disease. Definitely will have a lot of problems in planning radiation to avoid radiation pneumonitis. Lower lobe lesions require a lot of area to be treated. So again, pneumonitis is a possibility. Bulky mediastinal disease would also lead to problems in delivering radiation. So because of the lot of variation in stage 3A and stage 3B, even N3 also, you have small volume disease, large volume disease in the mediastinum. So that makes a huge difference. And nodes to the supraclavicular also would lead to a lot of problems. So overall, the summary of radiation to the stage 3A, where you do post-operative radiation treatment, or a neoadjuvant chemoradiation, and curative intent in an inoperable stage 3B, or a consolidation radiation in a palliative setting in a stage 3 and a stage 4 disease in a CA lung. Radiation has definitely made a huge impact in the management of non-small cell lung cancer. Now, finally, conclusions, an optimal RT, as Dr. Raja wanted us. When to deliver, wherever is a feasibility, you definitely have to be concurrent chemoradiation. And in a stage 3 setting, as a preoperative or a definitive, it has to be RT plus CT. And in a stage 3B, definitive CT plus RT. What dose? As of now, 60 to 66 gray. If you want to escalate the dose, it has to be SBRT as a boost. And what technique? Preferably IMRT and IGRT. And if you have a high pockets, big pockets, you can even go for proton therapy. Definitely helps in better dose conformity, reduces the radiation pneumonitis chances by reducing the dose to the normal lung. PET CT, 4D CT, and MIP definitely reduces the normal lung radiation by helping us in tumor volume delineation. Thank you very, very much for the patient hearing. And thank you, Dr. Raja, for involving me to give this lecture.
Thank you, sir. That was an excellent lecture. And you made the topic so easily understandable for all of us. And you really touched upon the various nuances of how you select your choices of radiation in stage 3 disease. And you also deliberated on the various techniques that are possible. And then you also touched upon the strengths and weaknesses of various techniques. And you also touched upon, interestingly, some of the emerging options, and you finally defined in a very simple take-home way, the way you would put it in one slide, how do we decide on these patients. That was a very, very excellent, very informative, but very lucidly present. Thank you, Sir Vijay Reddy.
Thank you, Dr. Raja. Thanks a lot.
Moving on, now we have the pleasure of having our guest speaker with us. He's internationally known lung cancer expert. We all know that. And he is the professor of oncology in the School of Medicine and Dentistry, Western University of Western Ontario. We have all heard Professor Mark Vincent's lecture several times in several forums. He is one of the foremost experts in lung cancer. More than that, he is one of the pioneers in translational research, and he has been really interested in the design and conduct of the clinical trials, particularly in the lung cancer field. And also he has led and he has really changed the settings and the treatment paradigms in many ways in lung cancer. His other area of interest is actually colorectal cancer. But today we'll be very, very eager to listen to him on some of his insights as far as the lung cancer and the immunotherapy goes. So we welcome you, Professor Mark Vincent. Thank you for joining us. Please, Professor, you may go ahead with your lecture.
Thank you. Can you hear me?
Yes.
Yes, sir. We can hear you, sir.
Yes, sir.
Okay, I will try to share my screen. Can you see that?
Yes, your screen is also visible, sir.
Okay, thank you, Dr. Raja. Thank you for that kind introduction. And I suppose it's good evening to all of you. And I'm sorry I'm not there in person. Hopefully things will get better in the future, and I think they will. So I'm going to be talking about the management of stage 3 non-small cell lung cancer, evidence and experience so far. And I'd like to thank the organizers and AstraZeneca for making this possible. So there are my disclosures. So the objectives here are just to increase the awareness of stage 3 non-small cell, to look a little bit into the issue of surgery or no surgery from a guidelines perspective, to talk a little bit about the multidisciplinary team, to review briefly the chemotherapy options and more specifically the basis for immuno-oncology and the update of the 4-year overall survival Pacific data with durvalumab, and if time permits to share some cases. So the epidemiology, staging, and historical overview. In Canada and North America, the stage 3 non-small cell lung cancer substage accounts for about 25 to 30% of our patients. They are heterogeneous. It's a mixed bag, and there's a lot of debate and controversy about how to manage them. But the survival ranges between 13 and 36%, depending on the exact type of stage 3, with traditional treatments, which have been chemotherapy and radiation. And certainly, stage 3 is a little bit different around the world. This is just a little bit of data from northern India, from Chandigarh, showing perhaps more of an accent on stage 3B in presentation than stage 3A. But I'm interested to see that you do diagnose this stage in non-smokers to some extent, and even some of them have squamous carcinomas, and that would be a little bit different from North America. The staging system project seems to go on and on and on. I'm not sure how much additional value each new iteration of the staging system provides, but as far as we're concerned, it's important to appreciate that there's now a stage 3C category, which consists of patients with high stage T, either T3 or T4, and N3 disease. And obviously, these are people with a lot of disease bulk who would generally have a rather poor outlook. In terms of the traditional management, we learned a long time ago that chemotherapy added to radiation does improve survival, and that radiation by itself can probably cure perhaps 5% of patients with a median survival of approximately 12 months, and that chemotherapy improves upon that, albeit modestly. And it became a standard of care, I think, in the early 1990s. We also learned that concurrent chemotherapy was somewhat better than sequential chemo radiation, which we've been practicing up till then. And but I do want to point out that this is not a large difference. There's about about 5% at 3 years and about 4.5% at 5 years. And I do understand that sequential radiotherapy may be all that's logistically possible in many parts of the world, including parts of Canada, actually. Although, if at all possible, we do try to enable concurrent chemoradiation. But it's not always possible. In ESMO, for example, the European Society of Medical Oncology have recognized that, and they state explicitly that if concurrent chemoradiation is not possible, then sequential chemoradiation is a valid alternative. And sometimes one's interested in sequential because concurrent can be more toxic. But I do want to point out that the original Dillman study, which in fact changed the landscape for us here in Canada and elsewhere in the world, was a sequential chemoradiation study and did show a 4-month increase in median survival and about a 10% increase in long-term survival and probably cure. That having been said, even with concurrent chemoradiation, the best we seem to do is, at least in standard practice, 15 months, 10 to 15 months, 5-year overall survival. So it's still true that unfortunately the majority of these patients will relapse and die of their disease. Now, I have made the point that concurrent chemoradiation is more toxic, and in fact there is a higher incidence, particularly of grade 3 esophagitis, going up from about 4% with sequential chemoradiation to about 20 to 40% in people who are treated with concurrent disease, concurrent treatment. And I'm particularly nervous about using this in elderly or frail people. We have traditionally here at least offered sequential treatment to patients who are elderly and frail if we think they can at least get away with some chemotherapy. We have attempted to make the toxicity better and to make the efficacy better with this study, the Proclaim study, which looks at the value of substituting pemetrexed for etoposide, still cisplatin-based. Unfortunately, in adenocarcinomas that did not show any improvement, but it was less toxic, I will say that, and we do occasionally use it. Consolidation docetaxel did not, unfortunately, improve anything, although this was particularly put forward by people in the on the west coast of the United States as being something that was very likely to work, and unfortunately it did not. Consolidation cisplatin-based treatment, unfortunately, does not show any benefit, and there's a meta-analysis that confirms this actually. We have tried manipulating the radiotherapy dose, the 74 gray. These curves split early and stay apart, but unfortunately, they're against the high dose radiation therapy. And some of these deaths were cardiovascular deaths, but not all of them. And there's been speculation that the higher dose of radiation therapy may have tipped the balance of immunostimulation towards immunosuppression, which is an interesting point that's going to be relevant to what we're going to be talking about later on. The addition of cetuximab as part of this study, it was a 2x2 study, actually did not show any improvement at all. And in fact, the addition of gefitinib was actually harmful. And this is a patient population who were not EGFR mutated substantially. So I just want to emphasize this is an EGFR wild type population. In our practice here, we went through a phase of using cisplatin vinblastine. This was partly because the top side was expensive, and we elected to go with vinblastine simply to save some money. But there's also the fact that vinblastine was actually invented at my university. So we did a regimen that we made up here with induction cisplatin vinblastine followed by a lower dose of vinblastine during the radiotherapy with cisplatin. And we got a median survival in people who got through it of about 24 months with about 20% cure rate, which is very reasonable. But in people who could not get the complete radiotherapy or people who couldn't get the complete chemotherapy dose, they did not survive as well. Now, these obviously are people who are more frail and probably have a higher disease bulk. So this is not a randomized trial. It's just a 300 plus patient experience over about a 10-year period. So I want to move a little bit to talk about resectability. And there is controversy amongst the surgeons, ranging from a more liberal interpretation to a more conservative interpretation. So this is a UK publication in the British Journal of Cancer, which seems to permit multi-station into surgery, as long as there's been pathologic staging of the mediastinum, as long as the surgeon can get an R0 resection, and as long as the nodes are not too big, etc. But it does permit a multi-station node dissection. This, also from the UK, was actually more conservative and suggested that a multi-stage into disease patients should not have surgery, but that it might be permissible either when you picked it up incidentally, if you're thinking it's stage 1, 2, and you come across stage N2 nodes, it's reasonable to take them, which I think all of us would agree with. But that you should confine surgery to, if you know there's a single station N2, that might be reasonable, but not multi-stage. So there's a range of opinion amongst surgeons, at least in the UK and certainly in this country as well. So to try to get some insight into this, the EORTC did a study of pathologically proven N2 patients who were offered chemotherapy and then randomized to either radiotherapy or surgery. So this is obviously not concurrent to chemoradiation. This is a sequential chemoradiation versus sequential chemosurgery. And they found that there was no benefit from the surgery. The hypothesis was that surgery would be better, and it is not better. Certainly, it's more disruptive and perhaps more dangerous a little bit, even though it's done skillfully. It's not better than radiotherapy. Now, the INT0139 study is a famous study. There was some Canadian contribution to this. This was over 400 patients with 3A disease, standard stage 3A, patients who might be potentially resectable. They were all offered cisplatin etoposide, 2 cycles concurrent with 45 gray radiation, which is not a complete dose of radiation. They were pre-randomized. After the chemo radiation, things stopped. They were restaged, and if they had no disease progression, they went on with their assigned treatment, which is in the one case surgery, and in the other case to complete 61 gray radiation. And then if they were fit and willing and able, they got some chemotherapy afterwards, which many of them did not, by the way. So this is the overall survival curve. This is real data. The yellow line is the chemoradiation surgery, and the blue line is the chemo radiation. And you see the curves cross here with a little bit of an advantage for the chemoradiation arm at the beginning, and later on a bit of an advantage for the chemoradiation surgery arm. So what's going on here, and what is going on when you see this kind of a thing, is that there's two opposing things going on. So they decided to do an interesting analysis, which some people think represents real data, but it's only real data up to a point. The yellow line is real data, and that is the chemoradiation surgery. That's exactly how they did, if they had a lobectomy on the left or if they had a pneumonectomy on the right. But the blue line is in fact just a matched group of people who the physicians thought would have had a lobectomy if they had gone to surgery, but they didn't go to surgery. So the blue line is hypothetical. It's a group of people who were matched to the people who actually had a lobectomy in the study. And on the other hand, over here, the blue line represents the survival of the patients on the control arm who, if they had gone to surgery, would have had a pneumonectomy. And what you see and what the message here is that this is an exploratory analysis. It's partly hypothetical, but it suggests that if you can get away with a lobectomy, there's an advantage for surgery. But if you have to have a pneumonectomy, there's actually a disadvantage for surgery, and it's actually dangerous. And it's dangerous because, as you can see from the steepness of this curve, there are post-surgical deaths. And the reason they're post-surgical deaths is because now the entire cardiac output is going into one lung, and the lymphatic exit from that lung has been partially irradiated and doesn't work very well. So it's very, very easy to tip these people into pulmonary edema, and I've seen 2 of them die like this. So we don't do pneumonectomies in the context of radiation at all. But another important message from this INT0139 study was that although surgery improves local control, and it certainly does, it does not improve the likelihood of metastatic relapse, and that most of the recurrences are metastatic. Having surgery does not significantly protect you from metastatic recurrence. Whereas if you look at the Pacific study, which I think you know is chemoradiation and then randomized to durvalumab or placebo, on the left here in blue, you see that the durvalumab will improve local control, it will improve lymph node regional control, and it will improve metastatic control. All of it is improved. Whereas with surgery, only the local control is really improved. Now, the Japanese have looked at the surgical results of resecting either multiple N2 or single N2. Multiple N2 resection is very poor. Single N2 is mediocre at best. They then divided the single station into single in the upper mediastinum or single in the lower or middle mediastinum. And the middle mediastinum single node resections or lower do quite poorly actually. And the only one that's even perhaps vaguely acceptable is the single station upper mediastinal node patients who were resected. But I will tell you that if this was breast cancer, this would not be acceptable. 50–60% 5-year survival would not be acceptable in breast cancer. So the NCCN have weighed in with a guideline, and what they're saying is that for any N2 patient, the category 1 recommendation is chemoradiation plus durvalumab. But surgery may be acceptable in selected patients. For N2, N3 patients with higher T stage, in other words, stage 3B, stage 3C, surgery is not indicated. And chemoradiation plus durvalumab is the category 1 recommendation. The NCCN, I'll emphasize again, and this is from an earlier one, emphasize here that they don't suggest surgery is appropriate in any patient where you know upfront that it's N2. But what they do is they provide chemotherapy recommendations here with sequential, for example, cisplatin vinblastine or paclitaxel carboplatin. For concurrent, they do permit carbopemetrexed, but also cisplatin metoprolol, which is the academic standard in the United States and Canada. But also you can go with vinblastine, and carboplatin paclitaxel is quite popular in the United States. We don't particularly like it here because we think it enhances the risk of radiation toxicity with the taxane, but we know it's popular in the United States. So you have a choice, but gemcitabine is probably not a good idea because of the intense radiation sensitization. So in my opinion, there's a restricted role for surgery. Medically unfit patients, pneumonectomy is a contraindication. Some T4N1, bulky N2 multi-station, don't do it. T3N1 may be considered if you can get away with a lobectomy. N2 single station, maybe in the upper mediastinum. But in my country, you will lose the funding for immune checkpoint therapy. You will lose the funding for durvalumab. So the patients and the surgeons need to be educated about that. So here's an interesting study from Korea, which shows in people who had trimodality treatment, chemo, radiation, and surgery, N2, and 76% of these were single station N2, that by 5 years, 70% of them had relapsed, and almost all of the relapses were metastatic disease. The bottom line is this. Stage 3 disease, even in stage 3A, and even many patients with single station N2, is a metastatic disease. It's a systemic disease from the beginning when you're aware of it for the first time from presentation. And if you do surgery, no matter how well it's done, no matter how technically proficient it's done, and they are very skilled people, you're closing the barn door after the horse has bolted. It's like what we learned about breast cancer a long time ago. It's very often a systemic disease, and doing super radical mastectomies did not make a difference. And so we're learning this now in stage 3 lung cancer. So the surgeon says, can I get an R0 resection? Sure, it's technically possible. Stage 1, stage 2, even some isolated metastases like in the brain and so on. But what's the chance of surgical cure? Well, it's high in stage 1, stage 1A, 1B, and maybe stage 2. But, even if you can do multi-station N2 or single station N2 in the lower mediastinum, the chances of surgical cure are low to 0. So even if you can do it, it doesn't mean you should do it. So this is a lesson as well, and it's a difficult one to learn. So I want to move on to the thoracic multidisciplinary board, which helps with this kind of an issue. Now, why is it important to present stage 3 to the MDT? Well, it's common, it's heterogeneous, it requires sophisticated staging. There's no single approach that's good for everybody. The management's often debatable. It's a rapidly evolving field, and the stakes are high because cure is possible. Here in London, it's mandated. We do it because it's mandated by Cancer Care Ontario. They do it in every disease site. It's now standard across North America and in the UK and in increasing number of countries in the EU. We do try to include the medical oncologists, not only and the radoncs and the surgeons, but also the diagnostic radiologists, pathologists, pharmacists we find are very helpful, respirologists sometimes, trainees. It's an incredible education experience, and it's organized by a dedicated secretary. We meet once a week for an hour. We take minutes. We communicate them to the GP, family doc. We rotate the chairmanship amongst various disciplines every 2 years. But unfortunately, we cannot present every single stage 3 patient. For sure, we cannot. So we tend to present the controversial and interesting patients. And we do have an academic corner once a year. The UK's NICE has supported this concept, but they say don't use it as a way to delay the patients because these patients can deteriorate quite quickly. So you should not delay patients. This needs to be organized efficiently. It's generally required by the health authorities for accreditation. It should be recorded and communicated to the GP. The MDT can have a role to play in the diagnostic route for the patients because there's a diagnostic component, there's a treatment planning component, and there's a treatment delivery component. And the MDT can play a role in all of this, but obviously, especially the treatment decision and planning component. Patients are more likely to get evidence-based medicine treatment and good standard of care treatment if they're presented to an MDT. And if you have to deviate from treatment for any reason, which quite often you do in medicine, you can at least get the coverage and the security that your colleagues have been informed and that you've discussed it with them and that even some of them will agree with it. But there is a potential for delay and there's a potential for disagreement. And so you have to have a mature clinician in charge of the rounds. And the technology has to work. It has to work perfectly. So what I've learned is that it's a collegial experience. No one's got all the answers. The secretary is very important. The technology always has to work perfectly, especially in this era of COVID. You should include a wide spectrum of disciplines. People are really trying to do their best, but we do live in different kinds of worlds. And it's important to have a forum where we can all communicate. The payers need to understand what the data is and what the evidence is and what the standard of practice is. If the payers are incentivizing something that was okay 10 years ago, then you're going to get people doing what was okay 10 years ago, because you always get what you incentivize. So it's critical that the payers are brought in at some point to understand the evolving standard of care. And really, it's an education experience. And if you open your mind, you'll always be educated by your colleagues, and you'll always be educated by the patients. And we know as well, if you're speaking in front of your peers, you're going to be up to date by and large. Just shifting gear, this is what happens to stage 3 in the United Kingdom. 30 to 40% get best supportive care. Only about 10-12% get the radical chemoradiation, and that's too low. Stage 3A, stage 3. This honestly is just too low. And this kind of data is helpful to understand from a QA point of view, what needs to be worked on and what needs to be improved. Not everybody is suitable for chemoradiation. I will say that for sure, but it's probably more than 10%. Now, the immunotherapy angle, there's a cancer immunotherapy, immunocycle, release of antigens, trafficking through dendritic cells to the lymph node. You jump over the CTLA-4 checkpoint. The lymphocytes are educated now. They're expanded into the circulation. They get to the tumor where they encounter the PD-L1 checkpoint, and at that point they may be switched off or killed, and you don't get the benefit of the immunity. Now, the effects of radiation are really to counter that, because you shed more antigens, you create a cytokine storm, and you enable trafficking of the immune system into the tumor in greater amounts. You also see the same sort of thing with chemotherapy, with the release of ATP, the upregulation of calretinin on the membrane, the release of HMGB1, so-called immunogenic cell death, and this matures the dendritic cells, which are then better able to present antigen to T cells, which are then more empowered and enabled to go around back to the tumor. But you do have this elevation of the PD-L1, which occurs because of radiation therapy. It's one of the things it does. It elevates PD-L1, and that is an off switch, don't eat me signal, and you have to block it with a PD-L1 antibody. And the individuals who figured all this out with checkpoints, Dr. Allison, who did the CTLA-4 checkpoint, and Dr. Honjo, who did the PD-L1 checkpoint, and they got the Nobel Prize, and very well deserved. So I'm going to update you now on the Pacific study, which took good performance status patients who'd had concurrent chemoradiation. You can have induction chemo here, but you have to have some element of concurrent, and no consolidation chemo. Then you randomize to Durva, 10 milligram per kilo every 2 weeks, versus placebo, and the primary endpoint is progression-free survival. But I will show you how the overall survival updated at 4 years. These curves separate early, they stay apart, they're starting to flatten, and by 4 years, there's an increase in 13.3%, which is about 1 in 7, 1 in 8 people who may be cured, may be cured. And the reason I say may be cured, because these curves are now parallel, not only to each other, but they are parallel to the x-axis. And this suggests that there may be about 14% of people who are cured over and above what chemoradiation can do by itself. This is a spectacular achievement. This is a milestone, not only in medical oncology, but in oncology and medicine and science. And it applies to the elderly people as well, who have a reasonably decent hazard ratio. Doesn't cross unity, perhaps not quite as good as in the younger people, but it's certainly worthwhile considering in the elderly. The elderly get a bit more toxicity, but you know what? They get more toxicity from the chemoradiation anyway. And it turns out that the number of patients who have to be discontinued because of the nivolumab, and that's really where the rubber hits the road, the deaths and the discontinuations, is only about 6%, 6 to 10% if you include the elderly. And in terms of what you get for it, compared to what you have to pay in terms of toxicity, this is a very good deal. That's not to say there's no toxicity. It's not to say you lower your guard. You have to watch out for it. Of course, you have to educate yourself, your colleagues, and also the peripheral hospitals where these patients may end up with pneumonitis, and they say, oh, it's a cancer, and they switch off the ventilator. Everybody has to be educated about toxicity, but it was much less of a problem than we feared. Even the never smokers benefit. Somewhat of a surprise, they seem to benefit with a hazard ratio that's better than the smokers. The cisplatin patients benefit a bit more than carboplatin. And the EGFR patients on the PFS at least seem to benefit as well. Whether they should get durvalumab or they should get osimertinib in future is an open question. So we have 5 pillars. We have surgery, radiation, chemo, targeted therapy, and immunotherapy, and we're in a new era. Now, at your discretion, I can go ahead and present the first case. Shall I do that?
Yes, Professor, please go ahead. Yeah.
Okay, so this is a 65-year-old man who has increasing shortness of breath, occasional green phlegm. He's a little bit obese. He has some hearing problems. He wears hearing aids. He's a hypertensive on Covasil, which is a perindopril. But apart from that, he's okay. And we decide to investigate him. He gets a chest X-ray in the emerge. And this is a chest X-ray that could have been missed, but they picked it up. There's a mass there behind the, I guess it's the second or third rib. You see it, there's a kind of a vague haze on the left here. This left lung is a little bit, it's not quite collapsed, but it's kind of starting to a little bit. The left hemidiaphragm looks a bit weird. You look at the lateral, the diaphragm's not quite right. There's a bit of a haze up here. So he has a CAT scan, and he has the spiculated mass in the left upper lobe, 2.5 centimeters, with a little bit of centrilobular and paraseptal emphysema. This is an ex-smoker. He quit 20 years ago, but he did have a 75-pack year smoking history. The mediastinum shows a large 4L lymph node, 4.8 centimeters. There's probably another lymph node over here. And he has a biopsy by EBUS of this hilar node. Sorry, not the hilar node, but the left paratracheal node is biopsied. This shows a TTF1 positive, very cellular specimen with focal gland formation. So this is clearly an adenocarcinoma. He has next generation sequencing, which we do now in everybody. And this shows a BRAF mutation, but it's a variant of unknown significance. So we don't know what to do with this. We decide to ignore it, or we just park it. Maybe it's going to become relevant later on, but not for the time being. And increasingly, we will be seeing this kind of a problem. You know, what do these weird mutations mean in the context of stage 3 or stage 1, stage 2? And we just have to park them to one side for the time being. So he gets presented to the thoracic MDT, and we agree this is all very well so far, but the staging is important, is not complete at this point in time. He needs an MR, he needs pulmonary function tests, and he needs a CT PET scan, which fortunately we are able to access here. So this is the MR of his brain. It's pretty good. This is the CT PET scan. It does show that the primary tumor is hot, as we would expect. It does also show that the large 4L node is hot as well, but also that there is this node here in addition, just lateral to the AP window. So this is a multi-station N2 disease. He's a CT1, N2M0. He's ECOG1. We decided to offer him a radical a curative intent chemo radiation. Because of his hearing loss, we decided to offer him carboplatin rather than cisplatin. Because he's an adenocarcinoma, we think it's okay to go with carboplatin pemetrexed. And we advise him that after this is all said and done, we're going to offer him 1 year of immunotherapy, so this doesn't come as a surprise. After 1 cycle and half the radiation, you can see there's an improvement. The left hilum is in a better position. The left hemidiaphragm looks better. The left lung looks a bit more aerated. This is at the end of the chemo radiation. This is the beginning. This is the end, going the other way now. We see that the primary tumor is kind of faded out. The left hilum is better and so on. So this is an improvement. And you can see that in the lateral, you can see this kind of area here is better. The left hemidiaphragm, which was elevated, is now back in a more normal position. So everything's looking better. It's confirmed the CT scan. This tumor mass is, well, it's not gone, but it certainly changes morphology. It's maybe it's dead, maybe it's not. The left hilum is better. The mediastinum is considerably better. And at this point, we start him on immune checkpoint inhibition. But because we're in the era of the COVID-19 pandemic, we've decided to offer the durvalumab at double the dose and twice the interval. So it's now 20 milligram per kilo every month. He starts on this. He's doing okay. The tumors continue to shrink. And by the way, that was seen on the durvalumabs on the Pacific study. On the active treatment durvalumab arm, the tumors continue to shrink, whereas that was not so much the case on the control arm, at least not to the same extent. So we do see evidence of continued ongoing response. No pneumonitis at that point, but by early April, we see that there's a patch of pneumonitis outside the radiation field. This is the radiation field. This is outside the radiation field. He's got some pneumonitis. We think maybe it's a patch of infection. Has some amoxicil. It doesn't really help. So he gets put on 75 milligram per kilo, so 75 1 mg per kilo of prednisone. We hold the durvalumab and we wean him slowly over 6 weeks. He sort of wants the summer off, but by August, the pneumonitis area here outside the radiation field has improved. We have stopped the Coversil, which is Prindapul, and that also can cause a cough, by the way. So all in all, he's better. The breathing's better. He's not coughing anymore. And we decide to continue. So we restart the durvalumab. We finish the 12 months. So he gets all of the treatment. So we include the gap, but then he has all of the treatment that he would have had during the gap. So the whole thing's completed. And this is the CT scan after, at the end of treatment. You really can't see the primary tumor in there. It's all fibrotic. There's a radiation kind of pattern to it. The lung looks sort of generally better, the lung fields, and the mediastinum looks great. So our plan with this gentleman is surveillance over the next over the next 3 years, with maybe a CT scan every 6 months. We don't do a CT scan every 3 months. That's too much. And that's really the way we do it here. So we don't know if he's going to be cured or not. Maybe he is, maybe he's not. But there are side effects from immune checkpoint inhibitors with the CTLA-4 and the PD-1. Maybe they're a bit worse. PD-1 may be a bit easier. That's a little bit of a controversy, but they're certainly better than the CTLA-4. And the pneumonitis was the one that we were concerned about, but you will see hypothyroidism. You should be aware of it. Occasionally, you do see other things, but with the durvalumab, we have been pleasantly surprised. And, you know, obviously, if it's more severe, you may have to think about IV methylpred or even infliximab. It is expensive, and you may have to permanently stop it. And it is uncommon that we've had to do that with durvalumab. I can only think of 1 or 2 people. So I can halt at this point if you like. I can carry on with the shorter case. I can do whatever you like.
Professor, you can carry on with your second case.
Thank you. So this is a 70-year-old female who's been smoking since the age of 10. She has a chest X-ray that's abnormal. She has some left-sided chest pain, and this is what she presents with, this sort of circular kind of opacity in the mid-zone attached, seemingly attached to the mediastinum. But if you look carefully, you can see there's a bit of an overlay sign. So you're not surprised on the lateral, actually, that the mediastinum is not actually involved, and this is in the posterior chest. And if you look very carefully, you can see the fissure. So this thing is going across the fissure. Because she had chest pain, we did a CT pulmonary angiogram in Emerge, and we can see there's no pulmonary embolus. The vessels go out nicely. She's obviously got COPD, but she does have this very large tumor mass here with probably some hilar nodes. It's difficult to disentangle it, maybe even some mediastinal nodes. But this tumor is definitely going across the fissure. This was followed by a referral and a PET scan. And the PET scan shows a largely necrotic mass, but there's a rim of viable tissue here. And also, by the way, some hilar and probably mediastinal nodes on the PET scan. But we decided to biopsy that viable rim. And this is what we see. We see sheets of poorly differentiated cells, which the pathologist nonetheless thought was not a squamous carcinoma and was more likely to be an adenocarcinoma. But the TTF1 is negative. We know, TTF1 is characteristic of adenocarcinoma, but 30% of adenocarcinomas, especially poorly differentiated ones, are TTF1 negative. And these have a worse prognosis. But this person had diffuse positivity for cytokeratin 7. So we know this is an adenocarcinoma. It's not a squame. Poorly differentiated adeno, P53 mutated, not targetable. Pulmonary function test borderline, FEV164, DLCO 40% are predicted. We finally staged it at that time as a T3 N2M0, but today with the 8th edition, because it's more than 7 centimeters, this would actually be a T4. In event, because of the age, the stage, and the COPD and so on, the surgeons obviously didn't want to go for it, didn't want to touch patients, so referred to MedOnc and RadOnc. And we got the same story. Patients now quit smoking. Her creatinine's low, she's kind of thin, but she's not emaciated. ECOG 0, albumin was normal. She really wanted to be treated aggressively because she's got a great grandchild on the way. She wants to see that baby born. But she had pain, and we said, you know, you can have some narcotics. Happy to do it. No, no, no. She said, I want my ibuprofen. I like my Advil. Could keep going on the Advil. So we give her 1 cycle of cisplatin etoposide under the cover of GCSF, because this is an induction cycle and we wanted to get on with it quickly. And the radiotherapy is being planned in the meantime. This is after 1 cycle. You know, it's not marvelous for sure, but she was okay. But she has got a bit of tinnitus. Her hemoglobin had dropped a bit. She was a little bit more short of breath. Platelets are up. The neutrophils are okay because of the GCSF. So now the radiation is going to start, and we decide because of the tinnitus that we're going to change to carboplatin and etoposide. There's 2 myelosuppressive drugs. We're worried about myelosuppression, so we decide to drop the dose by 20%. So that's what we do. And of course, we can't give GCSF because of the radiotherapy. So then about a week later, something happens. And I'll just give you 10 seconds to see what's happened. It's not difficult to see her abdomen does not look normal. She's got severe abdominal pain. She has a CAT scan and emerge. We see a lot of free air. She has perforated viscus. She goes to surgery. She has a ruptured, she has a perforated duodenal ulcer. They put on a patch. She comes out of surgery. She's unwell. She goes into the intensive care unit for 2 weeks. Her albumin is now 20. She's on antibiotics for 2 weeks. Large left pleural effusions drained, but actually it's cytologically negative. And then she starts to recover. She starts to recover. And as she's starting, she's extubated and so on. She's starting to get better. We restart the radiation therapy, but we say to her, no more chemo, no more chemo. And this perforation was probably because of the use of ibuprofen in large quantities, coupled with the dexamethasone with the chemo. Bit of a lesson there, okay? She starts the radiation and she completes the radiation. And this is the CT scan after the radiation. A week later, she's feeling better. She's feeling better. So I said, you know what, let's give you a little bit of a break. And then we'll talk about the development, because she's wanting the development now. This is the chest x-ray about a month after starting the chemo radiation, after stopping the radiation, compared to baseline. Quite a reasonably decent response, and certainly no evidence of disease progression. She's starting to feel better, and so we agreed to give her the development. And I've seen her now for 3 months, each time given her development, 3 cycles of development. Each time she's improved, she's better, she's got more energy, she's putting on weight, and that baby's coming in a month, and she's very happy, and I'm happy. And in fact, the development is not an immunosuppressive. So this is, as we've mentioned, it's okay in frail elderly people. You have to be careful. Of course, the trial was an ECOG 0 and 1. But we're going to get some information. I'll just skip through this to show that there's data coming. The data is coming from the Pacific R study, which is looking at sequential, because this was a kind of like a sequential case, more than a concurrent case. So we're getting some information about development after sequential chemoradiation. And in the Pacific 6 study, there's data from the first 50 patients that are going to be presented soon about development after sequential chemoradiation. And with that, I thank you for your attention.
Thank you, Professor. That was a scintillating lecture. Thank you so much, touching on all the important points. You literally, and then you walked us through your MDT, or rather, in your own words, rubber on the road. You really drove us through the MDTs, your patients, and what really happens in Canada. It was very, very heartening to see and hear that you also face similar problems that we face, and then you also take some ongoing decisions based on the best interest of the patient. Sometimes it may look adventurous, but finally, when the patient does better, we really feel gratified that we did have the courage to take such decisions. And that's a great learning point for all of us. And we really learned a lot hearing from you. And we request you to stay around for some more time with us. And moving on with the meeting, I invite my very senior professor, Professor Dr. Subramanian, to chair the next session. And he will introduce the moderators and the topic of the next panel discussion. He's one of the foremost medical oncologists in our country. He's an eminent clinician and is an eminent teacher. And he's one of my mentors, and I respect him a lot, and I've learned a lot from his wisdom. Professor Subramanian sir, you can take over the panel discussion from here.
My dear friends, at the outset, I would like to thank Dr. T. Raja for asking me to participate in this webinar. You are all aware, lung cancer is the commonest malignancy in this part of the world as well. Fortunately, our women do not have that much of cancer of the lung. But another problem in our country is that we don't see them in the very early stage. We see them mainly in the metastatic stage and often in inoperable stage 3 also. We have just the way forward is to create awareness among our public as well as our family doctors for over screening of cancer in general and also of lung cancer in particular, because lung cancer is the commonest malignancy in our part of the world also. The problem with lung cancer is that the ordinary methods of screening is not very effective, and we have to go for a low-dose CT scan in high-risk individual. Anyway, we have to do that if we want to save our people from lung cancer mortality. Now, you have just heard 4 excellent lectures on the management of early stage lung cancer from Dr. Ashish Singh, Dr. Krishna Prasad, Dr. Vijay Reddy, and Dr. Mark Vincent. Excellent lecture, especially on the immunotherapy also. Now we go on to case-based discussion of inoperable lung cancer. It's going to be moderated by Dr. Senthil Rajappa. I'm very happy to see Dr. Rajappa after a long time. He is our student in MMC. And Dr. Rajappa is a very senior medical oncologist and a dynamic and young, and he is working in Hyderabad, Prasad Indo-American Cancer Hospital and Research Institute. Dr. Senthil Rajappa.
Thank you, sir. It's really a privilege. Thank you so much for introducing me. I just was recollecting the great times that me and Dr. Raja had, let's say 20 years ago, working with you. Certainly actions of wisdom that we have imbibed and tried to emulate. Thank you so much for that introduction, sir. So what we will do in the next 25 minutes is we will have a case-based panel discussion, and our panelists are Dr. Poonam Patil, Dr. Prasad Iswaran, Dr. Rahul, Dr. Balaji is not joined in, Dr. Rakesh, and Professor Vincent. So the case that I'm going to discuss is something very similar to what Professor Vincent discussed, the second case of his. So this is a 65-year-old diabetic, a chronic smoker, presented with cough and chest pain and breathlessness of 12 weeks duration. He had lost 4 kgs in the past 1 month. The chest X-ray showed a left lung mass. I don't have the picture of that X-ray. He had a CT, and then a PET CT was done for this patient. So this is the PET CT that you're seeing. There's a huge mass with a lot of central necrosis here. Some mediastinal lymph nodes, again, not very clear on the cuts that we have. So this is a 9.8 into 6 centimeter left upper lobe mass that's infiltrating the costal and the mediastinal pleura. Few small paratracheal, subcarinal, and bilateral hilar lymph nodes. The largest is 1 centimeter, and that's PET AVID. Just as in Professor Vincent's patient, there's paraseptal and pan-acinar emphysema in both the upper lobes. There was some other reticular nodular opacity. So huge, nearly a 10 centimeter mass with some mediastinal and hilar lymph nodes. So that's what this patient was. So EBUS TVNA was also done. That's for the subcarinal node, which was positive. Right? So the diagnosis is a carcinoma of the left lung. It was an adenocarcinoma. The MRI of the brain was done, which is routine, and that was again normal. The PFT typically, as you see in most reports, was obstructive restrictive. the FEV1 was 65% of predicted value. Now that's moderate dysfunction, moderate function of the lung or dysfunction, whichever way you want to call it. So it's a T4N2 adenocarcinoma of the lung. So let me start by asking Dr. Poonam, is that workup adequate, or would you like to have some more information? Any role for doing molecular workup, doing the PDL1 in this patient?
Yeah, so thank you, Dr. Senthil. I would certainly go ahead and do it, but I would keep that knowledge with me, and that would not impact the current management.
Okay.
So,
right. So you would do it, you will keep it for a later date and use that information sometime. Rakesh,
later.
would you also do the NGS and the PDL1?
Yeah, so if the depends on the patient, sir. If the patient looks like a candidate who can tolerate combined modality of treatment, that is CTRT, chemoradiation, that is my primary differentiation. If the patient is able to tolerate CTRT, then probably my emphasis will be to start CTRT. If the patient doesn't look like a candidate for CTRT, then probably CT4N3, he has bilateral hilar lymph nodes. So I would probably do an NGS here upfront and see if we can go for any systemic treatment as like advanced cancer.
Okay, so there is an option of treating it like an advanced case is what
yes.
you're saying. Professor Vincent, do you routinely do an NGS and a PDL1 for your patients with stage 3B or stage 3C, whatever?
Yeah, we certainly do routinely PDL1 on everybody, whether they're stage 1, 2, 3, or 4. That's routinely done, not on small cell, but we do on every non-small cell that gets a biopsy. We'll have a PDL1 done, and in general, we're doing NGS on adenocarcinomas, but not squames.
So is it similar to why, what Dr. Poonam said, you want to keep it for the time being or use this information in the immediate treatment decision that you're going to make for this patient?
Yeah, so if the, I guess there's three, we look at it as one of three, they fall into one of three categories. Either they're obviously candidates for chemoradiation, in which case the information will be useful later. Or they're, obviously not, and they have to be treated as if they're metastatic, because some 3Bs are so bad that you just treat them like a metastatic disease, in which case we use the information immediately. And then there's this kind of borderline situation here, which I think you're creating, where, it's a discussion with the patient, a discussion with the team, and then you might want to do some induction systemic therapy to see if the patient perks up or the tumor shrinks, and then you can come in with some localized form of treatment later on. And then if you know that it's an EGFR mutation positive, that's probably one of the best treatments systemically if the goal is to shrink the tumor. So we get this information not because we will use it immediately, but because we probably will use it later on, and because sometimes we may use it if it's a borderline case to sort of tilt the patient one way or the other. We give them some systemic therapy and see which way it goes.
Okay, so sometimes used immediately, but most of the time in a patient who's going for concurrent chemo RT, you would probably use that information later, just like what Dr. Poonam clearly said. Dr. Prasad, would you also agree with the same, or do you have some different thoughts?
So Dr. Prasad is not there.
Prasad is also not there. So we've got Rahul.
Yeah, so I think I also agree with Dr. Vincent, Dr. Poonam on this, and we have the options definitely. And many times when we discuss such a case in a multidisciplinary tumor board, probably the radiation oncologist may tell us, okay, probably go ahead with a cycle or two of chemotherapy and then probably reduce the size of the tumor so that they can fit it in their portal. So yes, I would like to do it upfront so that we have some options which are there. I would, if the patient goes for CCRT upfront, I would like to keep it at the back of my mind.
Very good. So all of us agree that it's good to do both of these tests. Maybe use that information immediately or use it later. It depends upon what ultimately your patient is going to get to. So Rahul, since you're there on the screen, what would you do for a patient like this? So let me tell you what happened. So we discussed this patient in our multidisciplinary tumor board. We said if it's possible, we should do concurrent chemoradiotherapy. Then they went in for the radiation planning, and then after the planning, they came back and said that the amount of lung the V20 that Dr. Vijay was actually discussing earlier was more than 30-35%, which would predict for a very high incidence of radiation pneumonitis. So they were not happy to do concurrent chemo radiotherapy. So what would you do in a situation like this? So this patient's EGFR was wild type, and the NGS did not reveal any actionable mutation.
Right. So I think in such a situation, I think the induction chemotherapy is what we would like to give to this patient. And probably a combination, what we prefer at our hospital is a taxane plus platinum based. I know people prefer Prasad. Sorry. Yeah. So chemotherapy and probably reassess him following 2 or 3 cycles for further management.
Professor Vincent, let me bring you in here. You made a very interesting point saying that one of the best ways to reduce this tumor, if it was EGFR mutant, would be to give anti-EGFR therapy, the TKI. How would you really incorporate it? Would you start with it, shrink it, then do chemoradiotherapy, and then put this patient on durvalumab? Or what would your sequencing of therapy be in a situation like that? Or would you say, I would not use durvalumab in a situation like this? So we are coming to this early since you made that point, though I have a couple of slides towards the end. Professor Vincent.
Yeah, you know, I don't really know how to answer this question with right. Data. But I kind of think you just you've got to climb to the next mountaintop. And I think the next mountaintop is to shrink this so you can get some definitive local treatment.
Right.
And so I think the best way to shrink EGFR mutation positive tumors is with EGFR mutation, EGFR mutation directed, an EGFR TKI. In future, I know that you can combine EGFR TKIs with chemotherapy. You can do it in an intercalated kind of way. It is possible to do that. And some people might even be tempted to do that, and I have done it in the past. But I would say that if it's an EGFR mutation, the most likely way to shrink this tumor is with an EGFR TKI. And after a month or 2 of that, you can then restage the patient and decide, is there some kind of an option for aggressive local control, either surgery or radiation? In this case, not surgery, but maybe chemo radiation. I certainly wouldn't give the EGFR TKI concurrent with radiation therapy. We just don't have the data to support that that's safe. Maybe it is, maybe it isn't, but we don't have the data to support it. So at that point, I would probably stop and switch over to chemo or chemo radiation. And then at that point afterwards, now you have to make a decision. The EGFR TKI is washed out of the body. It's probably safe to give durvalumab. It's also, in my opinion, not unreasonable to continue with the EGFR TKI if you can get the funding, especially for something like osimertinib, which will protect the brain, as well as be a very good thing to suppress, the resistant forms. But it is a little bit flying by the seat of your pants here a bit, because there isn't a lot of data in the situation.
That's it's
an issue, right? It is an issue.
Absolutely, right? It's an issue because we are doing more of these molecular tests these days, and then you get stuck. Because on one hand, you say that PD-L1 inhibitors are not the best way to treat patients who are mutated, and then on the other hand, we don't have data to not do it. So that's a kind of a dilemma that you face every day. So as I said, this patient was EGFR wild type. So we used as Rahul said, 6 weeks of Paclitaxel carbo, and then we repeated a scan, and this is what the scan is. It's absolutely the same as where we started. 8.9 into 5.9, that was some 7 centimeter by some 9 centimeters. So it's just a millimeter here. So it's stable disease, and the mediastinal lymph nodes are also the same. Rahul, let me come back to you. Change of chemotherapy, radiation alone, or jump into chemoradiotherapy with some attenuated chemotherapy, as what Professor Vincent did in his patient. What would you do?
I think the change of chemo does not make sense at this moment. But yes, there are options where people do change the chemotherapy, but I would still gun for a CCRT at this time. I think.
Right, Rakesh, and then Dr. Poonam.
So if the tumor has not changed, then it wouldn't change the radiation portals as well. So it will be putting the patient at a higher risk of toxicity. Of radiation pneumonitis. So probably again it will go into an MDT discussion, and I would tend to if MDT decides for CTRT, then I would tend to change the chemo arm here. I will rather do pemetrexed cisplatin here in combination with RT.
Very good. So pemetrexed cisplatin and RT, though there is still a high risk of radiation pneumonitis. All right, doesn't matter. So Rakesh, would you think that it's changing to be palliative at this point in time?
Yeah, it looks like palliative. I mean, on top
like
everything, it looks like palliative. Yes, you are very right.
Looks like palliative. Dr. Poonam?
I would not look at radiation because if V20 was excluding radiation, it would not make his quality of life any better if I use CCRT anyway now.
Right.
So
you would, yeah, go ahead. Sorry, go ahead.
So I would probably continue with, since it's a stable disease, it's not disease progression, I would probably go with 2 more cycles of the same therapy. But yes, it would be more towards the palliative side rather than the curative side. After 4 cycles of carboplatin and paclitaxel, if there is some further tumor shrinkage, I am at an advantage for some kind of local therapy. Otherwise, it would be more towards palliation now.
Very good. So there is a tendency to think at this point in time that it's getting to be palliative because there isn't any response to first-line chemotherapy, but all of us are tempted still to look at a potentially curative intent / an intent where the survival is to be prolonged. Professor Vincent, what would you do in this situation?
You know, we would have the information about the PD-L1. I wouldn't be surprised if this patient had a strong PD-L1 positivity, you know, more than 50%, in which case we might have a fling at some kind of some immune checkpoint therapy, either to add that to the chemo or to go as a monotherapy. If it's higher than 50%, we have the choice to do either. So, you know, I would say I'm also still nervous about the radiotherapy, although you could, it's a bit of a gamble to do it. You could do it in some kind of attenuated way, maybe, but you're unlikely to cure this guy if you attenuate anything. So I would have a look and see, you know, is there an option for immunotherapy with this gentleman? I guess that's the question, because we would have the PD-L1 status.
Okay, we didn't actually have, unfortunately. Yeah. So we didn't look at the immune checkpoint inhibitor as an option at that point in time. So we just changed, as Rakesh said, to pemetrexed and cisplatin. The reason we continued to persist with the platinum was we said, okay, if you're looking at response, cisplatin might be a slightly better platinum compared to carboplatin. And then pemetrexed is typically what we use for adenocarcinoma. So let's jump from that. Yes, the thought of whether this is going to be palliative came up, but we said, okay, let's give it a try. And fortunately, for us, there was a partial response. So, though I don't have the scan, it came down to somewhere around 5 centimeters from 9 centimeters. So that was a dramatic response, which we ourselves didn't think would happen. So he was symptomatically better. There was some fatigue. His performance status was between, 1 and 2. So Rakesh, now radiation versus chemo rates.
I would tend towards radiation only, sir.
You would be tempted to do radiation only. Dr.
Radiation
Prasad,
only.
Okay. Any specific reason, Rakesh?
He already got about 6 cycles of chemotherapy, combination chemotherapy.
Okay.
So, I mean, we already pushed it a bit with a palliative, high palliative intent. So we already achieved some sort of response. So I think.
So you're happy with that response?
Yes.
And then you say radiation. Dr. Poonam?
Sequential RT, it will become something like sequential chemo.
All right. Correct.
So happy with that.
Very good.
So what is our intention now of treatment here? Are we looking at cure or are we looking at palliation?
I don't know, Dr. Poonam. Whichever. So I think the response gives you a little bit of a temptation to say, I will put this patient on durvalumab after radiotherapy, because there's super data to say that at least nearly half of all patients may be cured. So I would say that with this response, I'm tempted to say that potentially curative.
So what Dr. Vijay and Reddy had told us about the newer modalities of radiation.
Okay.
If we could use them, because if we are looking at cure, then we are also giving him the toxicity of radiation. Now, though the toxicity would be reduced probably because the V20 would come in the
acceptable ranges.
Acceptable range.
Very good. So we are saying chemoradiotherapy. Dr. Prasad, you've joined just in.
So we're looking at a potentially curative intent. So in any potentially curative intent, the god shouldn't be let down. So probably my suggestion, my personal approach would be to give some form of chemotherapy to potentiate the radiation.
So what of these 4 would you choose, Dr. Prasad?
At least carboplatin as a single agent should be definitely be useful compared to giving radiation as a single modality.
Okay, Professor Vincent.
Yeah, so I think if the cisplatin pemetrexed was well tolerated.
Yes, it was.
With the folate and all that. I would be tempted to continue with that during the radiation. But the patient has to be informed that this is a high risk strategy and the patient has to be fully on board.
Right. So that's quite a bit of an aggressive strategy. So we did think about it based on that proclaimed data, but we're still not used to doing pemetrexed and platinum in our hospital as a radiosensitizing protocol. So we did something like what Prasad said. We did do some sensitization with carboplatin, AUC2 every week. And fortunately for us, completed 60 gray and then went home to come back after 4 weeks for an evaluation. So Rakesh, when would you evaluate? 4 weeks is good time or a little later?
4 weeks is a good time for me to evaluate, sir. I'll
CT or a PET CT?
4 to 6 weeks.
Okay, CT or a PET CT?
At this point, CT.
At this point in time, CT. Dr. Poonam, CT or PET CT?
CT scan.
CT scan. So, Professor Vincent, is that what you do in your hospital? When would you do an evaluation to assess eligibility for durvalumab? 4 weeks, 6 weeks later, or earlier? Because there is some data that if you start early, you might actually have better results.
Yeah. So we would book the CT. We would book the CT evaluation at, when we see the patient about halfway through the radical radiation. That's when we book the CT. So there's no delay. And we try to get the CT within about 2 weeks from the end of radiation.
Okay.
And try to start the durvalumab a little bit earlier as possible, because as you say, there's some data that if you do it within 2 weeks, it's better than if you do it between week 3 and week 6. But we know that a lot of these patients are beaten up and, may end up delaying the evaluation to about 4 to 6 weeks, just because they're having to recover and don't want to come into hospital, etc. So you can't always get exactly, it can't always be perfect.
That's correct. So these people are beaten and battered at the end of their therapy. So let me ask you, Professor Vincent, do you think this 2-week starting of durvalumab, early starting of durvalumab, showing better results, is it because of biological selection, because you're choosing a set of patients who have good performance status, or do you think really there is a biological basis to this early starting resulting in better outcomes? So what is your thought?
Yeah, and I think either of these things are possible. And for that reason, I'm uncertain. Like many things in life, I'm uncertain.
Right.
And if you're uncertain, you've got to, one way to do it is to say, well, I don't know, but it may be that there's a genuine improvement from starting it earlier. It's possible. And so we should try to go with that if we can, even if we're not sure whether it was a performance status frailty issue, or it was, as you say, that it's genuinely better to do it early. But I know the hypothesis is that earlier it may be better. And so they're even doing it now concurrent with the chemo radiation, the durvalumab concurrent. And that's a study that we're waiting to see what the results will be.
So if possible, start early, but make sure that you're not rushing in too early with your patient who is frail and with poor performance status, because you might get into trouble with that therapy. So use your judgment and wisdom as much as your scans. So of course, this patient ended up having some radiation pneumonitis. There is some limitation of activities of daily living. So Rakesh, what would you do in a patient like this? This is 4 weeks after chemorad. So plenty of chemotherapy and then some chemorad.
Okay. So one thing is, how sick is the patient? Or is that
doesn't need
saturation?
oxygen, but there is at room air the saturation is 95 plus. So now it's COVID time, so everybody is asking this question. Is it
right? Fine. So
but there is limitation of activities of daily living.
Okay. Start off with prednisolone, sir, 1 milligram per kg. And at least give the full dose for 2 weeks at least, and then taper off over next 2 to 4 weeks, depending upon how the patient is tolerating.
Okay. So, Dr. Poonam, when would you think of consolidation durvalumab for a patient like this?
So generally 4 weeks after, within 4 weeks of stopping radiation.
Okay, so for this patient who's now had radiation pneumonitis at the end of 4 weeks, needing 1 milligram per kg of steroids and then some tapering, did well. So it took 6 weeks for the steroid taper to come to a point wherein we could say, okay, now this patient is fit to get onto some durvalumab. So is that what you do? How long would you wait routinely in a patient who has pneumonitis?
So if there is a underlying condition which is requiring steroids,
yes,
that is a different issue compared to steroids due to durvalumab side effects.
no, this is radiation pneumonitis.
Yeah, so
needing
this is
steroids.
radiation pneumonitis. So as once the patient is comfortable, I think we can start durvalumab and parallelly taper the steroids as much as we can.
Okay, Prasad, do you also agree?
I would completely wait till the about 8 to 12 weeks.
Okay.
Reason being that after radiation and after so much of chemotherapy, we need to have the breathing time for the patient to recover from all the radiation pneumonitis and all the side effects of the previous treatment. That is number one. And durvalumab, though it has an improvement in the survival, it does have complications also. So we don't want to have the overlapping lung toxicity because of drug onto this pre-existing radiation pneumonitis, which may probably kill the patient even. So I would, my personal choice would be to let the patient recover for at least about 8 to 10 weeks and start with durvalumab after about 12 weeks duration. Sir.
Okay, very good. I do agree with it. Give the patient some breathing time. Professor Vincent, how late can you really start durvalumab? Because there are some patients who are sick, who get better 3 months, 4 months. Now they're all right. The scans look really good and you're tempted to put these patients on durvalumab. There is some real world data about delayed initiation of durvalumab. Can you enlighten us on that?
Yeah, I mean, we are restricted by our funding agency. So if we want to start it late, we've got to get special permission because they do want us to start it within 6 weeks. On the other hand, in this case, the patient's still on prednisone and still weaning and still getting over the radiation pneumonitis. I definitely would agree with the previous speakers that you shouldn't start them until you're kind of the prednisone's right down or you're off it. And the radiation pneumonitis has at least resolved to a grade 1, right, at least. May never get completely better. And then again, you start to discuss with the patient about what the risk is and what kind of risk level they want, because the risk is also about what the patient's prepared to accept, as well as what we think. You know, when you do risk assessment, it's a two-party discussion. So I would try to start as soon as I can, but not before the pneumonitis is down to grade 1 and you're down to the prednisone at least 5 milligrams a day or off it altogether. And then we have to ask our organization for special exemption to fund beyond 6 weeks.
Okay, but would you say it's okay to start late, 3 months, 4 months? Do you still think that there might be some efficacy?
Yes, I do, because you know, we know that this is like a systemic treatment anyway, and we would certainly not hesitate to start pembrolizumab if the patient had liver metastases or something. So I think it's very reasonable to start the durvalumab late. You know, do you get exactly the same benefit? Who knows? You know, there are many things you'll never know. Right. But I think it's a very reasonable thing to do, given the drug is relatively benign, and I stress relatively benign. But of course, in this person, you're really concerned about flare of the pneumonitis. So you have to keep this patient on a bit of a tight leash. It's not just go away for 3 months and, you know, that kind of thing.
Right. So wait for the pneumonitis to settle, grade 1, 5 milligram, 10 milligram of prednisone. That's the time you start talking about durvalumab. You can start late. Though there is some real world data that the efficacy could still be preserved. So my last question to, Professor Vincent has already answered this question, but let me ask the 3 our panelists, what would you do, Dr. Poonam, if this patient was EGFR mutant? Would you follow the same thing that Professor Vincent said, or you have different thoughts?
No, I would follow the same what Dr. Vincent suggested.
So shrink with an EGFR TKI, then do chemoradiotherapy, and then do what? Would it be an EGFR TKI, or would you do durvalumab?
Probably continue the EGFR TKI.
You would continue the EGFR TKI. Rakesh, and then Dr. Prasad?
So, truly a most difficult scenario, probably. So, what I would do is
you, Rakesh.
Yeah, no. What I was so we don't have. Neither the specific study to inform us. Probably we'll have to wait for Laura to come up. And if it is a high burden stage 3B disease, I would not do CTRT at all in this patient, sir. I will directly go to only EGFR TKI. If it is like a low volume disease and CTRTable disease, easily CTRTable disease, probably then I would do CTRT and put the patient on follow-up at that particular point, wait for progression, and then redo EGFR TK at that particular juncture.
Okay.
I have burnt my hands with doing post-CTRT EGFR TK in a couple of patients with bad radiation immunities. Don't know whether it is due to radiation or because of radiation recall secondary to EGFR TK. That is well reported as well. So this will be my two scenarios: high burden disease and treat straight away as an advanced disease with EGFR TK. Palliative, low burden disease, CTRT, and then observe.
Great. Dr. Prasad?
I would go with what Rakesh had said.
You would go with, that's a short, sweet, nice answer. So I think we still don't know the clear answer to that question. Just like Professor Vincent said, you'll have to use your wisdom. That's what we started this with, Professor Subramanian's wisdom. So we'll end with wisdom here. Again, that's very, very important when you're managing a patient. This is that someday we will have a biosimilar so that we can use it on many more of our patients. So that's my summary slide. I think some phenomenal data in locally advanced disease with the consolidation durvalumab in patients who are inoperable and have undergone CTRT, nearly 50 months of overall survival, a PFS of 17.2 months, 4-year survival, something like it's plateauing off at nearly 50%. I think that's a phenomenal outcome. You could start even beyond 42 days, though every area might have its regulatory issues, but not certainly in our practice. It's the only treatment that's improved overall survival, and that's the standard of care in this setting if your patient does not have any contraindications and can afford the therapy. Thank you so much, Dr. Raja, for asking me to do this panel when I hand it over back to the organizers.
Thank you, Dr. Rajappa, for the excellent case-based discussion. We expected the usual complications and effects. Now, the one point I would like to say is that in an adenocarcinoma of the lung, my chemotherapy option would be cisplatinum and pemetrexed. It's a safer combination, effective combination. We don't use vinblastine because of the venous issues. Not many patients, ours, are going to have a venous core. And the paclitaxel is definitely a little toxic in an elderly population, whereas pemetrexed is quite safe. In fact, just to mention, one of my metastatic CA lung has gone on for cisplatinum 6 cycles with pemetrexed and only pemetrexed maintenance. And last week, he continued to have 109th injection of pemetrexed. Has gone on for 10 years without any side effects. He is doing a normal work. So just to emphasize the safety of pemetrexed. Anyway, this case has produced a very good understanding of the various problems of things. Durvalumab is definitely a very interesting drug. Not many of our people can afford it, but in curable situation, we should persuade the patient to go for a durable response with durvalumab. This, I thank Dr. Raja for my participation. Thank you.
Thank you, Professor Subramanian, sir, once again for that exciting case that you have, 109. That's amazing. That really encourages to consider whenever we have patients who are crossing the 30, 40, 50 now, which is, we think how long. So now I know the next goal post. Fantastic. And once again, excellent, panel discussion as usual by Dr. Senthil. Amazing, insights from Professor Vincent on that also. Dr. Senthil, you finally didn't say whether you ended up using durvalumab or not in this.
I showed the car with the Ferrari, so that's the answer to the question. The car with the horse, sorry, not the Ferrari. So that's the answer.
No, I know. Thank you for that excellent lecture. Now, moving on with...
Thank you, sir.
Thank you. Now, moving on with the next lecture. I'm inviting Professor Dr. Narayanankutty Warrier, and he's my very dear friend, and he's the director and head of the Department of Medical Oncology, MVR Cancer Center, Calicut, Kerala. He's going to speak now. The next 1 hour of so we're going to deal with the small cell lung cancer. He's going to speak on immunotherapy in first-line extensive stage small cell lung cancer. Dr. Warrier, please.
Thank you, Dr. Raja. It's a wonderful evening and nice to be here. And thanks for your invitation. The small cell lung cancer has been historically very tough disease to treat. And if you look at the progress we made in the treatment of small cell lung cancer, you can see that not much changes in the last 30 years or so. But however, the last 2 years were very exciting. Next slide. The reason being there are two immune checkpoint inhibitors have got approved in the management of resectable stage small cell lung cancer. So looking at the way the progress in the management of small cell lung cancer was made, you can see that the doublet platinum with etoposide or irinotecan was the standard for about 3 decades. And the last 2 years, there is some change in the overall survival. Till 2015, we never got any change in the overall survival at all. So this is something very exciting, and probably this will be the gold standard. This will become the gold standard in the coming years. Next slide. The small cell lung cancer is initially chemosensitive, and most patients relapse after initial treatment. And approximately 80% of the patients with the limited stage disease, and almost all patients with extensive stage disease, relapse with a median progression-free survival of 4 to 6 months following standard first-line therapy. Next. Next slide, please. Next slide. Yeah, but previous one. Yeah, the extensive stage small cell lung cancer is incurable, and about 30 to 50% of the patients will be eligible to receive the second line treatment following the first line treatment. And if you look at the third line treatment, only very few, less than 20% of the patients will receive third line treatment. Next slide. Small cell lung cancer is one of the few solid tumors which has got a very high tumor mutation burden. What does it mean? We have a possibility of inducing tumorigenicity, and subsequently the immunity can be boosted, so that we can probably make utilize of the enhanced immunity against the tumor cells. Next slide. There is a synergy between the immune checkpoint inhibitor and the chemotherapy in small cell lung cancer. And if chemotherapy, for that matter, chemotherapy can induce tumor cell killing, which may in turn induce a tumor antigen release and exposure to immune system. The PD-L1 overexpression leads to immune cell inversion and T cell inhibition. The PD-L1 inhibition restores tumor-specific T cell immunity, and the reversal of immune suppression leads to deeper, more durable systemic anti-tumor response. Next slide. So we have, so far we have seen only the chemotherapeutic doublet, combination of platinum and etoposide or irinotecan for the management of extensive stage small cell lung cancer. But the last 2 years, with the approval of, with the results of the 2 randomized phase 3 trials, 2 molecules, 2 immune checkpoint inhibitors have become one of the mainstay of treatment for the management of end stage, the extensive stage small cell lung cancer. So we have the immune checkpoint inhibitor combination with the chemotherapy. And so that the NCCN, next slide, NCCN has come out with the recommendation of a combination of carboplatin etoposide with atezolizumab, or carboplatin etoposide with the durvalumab and followed by maintenance of durvalumab or atezolizumab as maintenance till the disease progresses. And the advantage of durvalumab is it can be combined with cisplatin as well. Next slide, please. So the first trial which tested that immune checkpoint inhibitor along with chemotherapy in the extensive stage small cell lung cancer was IMpower 133, where atezolizumab was with a combination of chemotherapy compared with the control arm, which is consisted of carboplatin and etoposide. It is a double-blind randomized placebo-controlled trial. Next slide, please. So IMpower 133 is a double-blind randomized placebo-controlled trial. Evaluated atezolizumab plus carboplatin plus etoposide in the first-line management of extensive stage small cell lung cancer. And the study arm is consisted of atezolizumab added to the combination of carboplatin and etoposide. And after the 4 cycles of chemotherapy, atezolizumab combination, atezolizumab alone was continued till disease progression. And this was compared to the control arm, where a placebo was combined with the carboplatin and etoposide. And after the 4 cycles of chemotherapy combination, the placebo alone was continued till progression of disease. Here, the patients with the treated asymptomatic brain metastases were also included in the study, and the co-primary endpoints were overall survival and investigator-assessed progression-free survival. The key secondary endpoints were objective response rate and the duration of response, in addition to the safety. Next slide. So all the baseline characters were matched in the 2 arms, and everything like the smoking status as well as the brain metastasis and all even the age group were matched. Next slide. So this is the overall survival, which clearly shows there is a survival benefit of 12.3 months in the atezolizumab with the platinum etoposide combination arm compared to the placebo plus the chemotherapy combination. The median overall survival is 12.3 months compared to 10.3 months in the placebo chemotherapy combination. There is an impressive hazard ratio of 0.76 with a 95% confidence interval, and the p-value is 0.0154. The median follow-up was 22.9 months. You can see that at 12 months, initially the overall survival curves were together, and you can see the survival curves were diverging, and this divergence is maintained throughout the follow-up. Next slide. Looking at the various subgroups which who were benefited, the overall survival benefit was consistent throughout all the subgroups, and you can see the only change here is the brain metastasis. Those who had the brain metastasis initially, and both the groups have not shown any difference in the overall survival. Apart from that, all the subgroups were benefited with the addition of atezolizumab to the chemotherapy combination. Next slide. So the IMpower 133 also showed a good progression-free survival of there is a improvement in the median progression-free survival of 5.2 months in the atezolizumab chemotherapy combination compared to the 4.3 months in the placebo chemotherapy combination. And if you look at the median survival in the atezolizumab group, it is 5.2 months. And the overall survival, you can see that there is not much difference in the overall survival in the 2 arms. Next slide. As far as the safety is concerned, not much concern about the safety, and all the grade 3 and grade 4 adverse events are hematological toxicity, whereas the immune mediated reactions like for the immunotherapy arm was majority of them were rash and hypothyroidism. Next slide. So the IMpower 133 has clearly shown a survival advantage, and coming to the next randomized controlled open label phase 3 trial, which is a Caspian trial, where the durvalumab, another checkpoint inhibitor, was combined with the platinum etoposide combination. And next slide. This is the Caspian trial design, where there are 3 arms, and the treatment naive extensive stage small cell lung cancers were randomized to receive durvalumab either in combination with another immune agent like anti-CTL4 tremelimumab, along with the standard doublet chemotherapy combination of etoposide and platinum. Which was compared to the standard etoposide platinum arm. And the main advantage here is you have the choice of having the platinum, and the investigator could select the platinum agent which is indicated in the particular patient. And all the chemotherapy, immunotherapy combination, where after 4 cycles, durvalumab alone was continued till progression, and durvalumab was given 1,500 milligram once in 4 weeks until progression. Subsequently, the durvalumab plus the tremelimumab combination with the chemotherapy showed greater toxicity and was withdrawn. Another advantage of this trial is here the control arm. The patients were offered 6 cycles, the full cycles of etoposide, the platinum, and the control arm were allowed to go for optional prophylactic cranial irradiation. Also, at the beginning, the asymptomatic brain metastasis, or patients who had treated and remained asymptomatic brain metastasis, were included in the study. Next slide. The primary endpoint of the study was overall survival, and the secondary endpoints were the progression-free survival and the safety and tolerability. Again, the baseline characteristics were equally matched. Here, there is a perfect matching. Even the country, the race, everything, and the brain metastasis, everything was matched. Next slide. And almost 60% of the patients in the control arm got all the 4 cycles, and they could complete the 6 cycles of chemotherapy. The durvalumab etoposide platinum combination, it's about 86% of the patients received these planned 4 cycles of chemo immuno combination. Next slide. So subsequently about 40% of the patients after progression with the immunotherapy or with the initial treatment have received a second line of treatment. Next, and the median duration of follow-up was 25.1 months. And this is the updated overall survival. You can see that the durvalumab, when added to the etoposide platinum combination, has got a survival advantage, which is clearly shown by the survival curves, where the survival curves have started diverging from 12 months onwards. And you can see that there is an improvement in the median overall survival, where the when durvalumab was added to the etoposide platinum combination, the overall survival was 12.9 months. Compared to the 10.5 months with the etoposide platinum combination. And the hazard ratio was 0.75 with a 95% confidence interval. The normal p-value was 0.0032. And if, next slide, also, there is a significant observation from the studies. Almost 20% of the patients at the and updated follow-up 24 months are still alive compared to only 14% in the control arm. Next slide. So again, the benefit of overall survival is maintained throughout the various subgroups. Next slide. Even the brain metastasis, whether present or not, have responded, has survival advantage. And if you look at the objective response here in the durvalumab plus etoposide platinum arm, there is a overall response rate of 67% compared to the 58% in the chemotherapy alone arm. And the median duration of response, there is a good observation here, where there is a difference in the response rate between the two arms, but there is this higher response in the immunotherapy chemo arm is continued even after 24 months. Next slide. So this is the updated progression-free survival, and though the progression-free PFS was not formally tested, but you can see that there is a median progression-free survival of 5.1 months compared to the durvalumab etoposide platinum combination, compared to the 5.4 months in the etoposide platinum combination. And the next slide. One of the major poor prognostic major poor prognostic factor in the case of small cell lung cancer is the brain metastasis. Here there is a survival analysis based on the baseline brain metastasis. You can see that overall survival in the Caspian study based on the brain metastasis has also shown that there is a improvement in overall survival in the durvalumab plus chemotherapy arm compared to the control arm of chemotherapy alone, and patients were benefited regardless of the presence of baseline brain metastasis. Next one. So same observation also is made in the case of progression-free survival. And if you look at the progression-free survival based on the baseline brain metastasis, you can see that the benefit was consistently improved with the PFS benefit was consistently improved with the durvalumab plus etoposide platinum versus etoposide and platinum alone arm, regardless of the presence of baseline brain metastasis. Next one. Again, if you see the patients who have progressed, the choice of second-line chemotherapy was very well maintained. You can see that about 40% of the patients have received subsequently a second line of chemotherapy following the study in both arms, study arm as well as the control arm. Next slide. So regarding the safety, just like the IM Power 133, Caspian study also not raised any serious concerns, and the grade 3-4 adverse events were all hematological toxicities, and the immunotherapy related side effects were rashes and hypothyroidism. And one significant observation made in the chemotherapy combination is, next slide, adding immunotherapy to the combination of chemotherapy will not increase the toxicities, and there is an interesting observation that there is less use of colony stimulating factor in the durvalumab plus chemotherapy arm compared to the chemotherapy alone arm. And also the limited blood transfusions required in case of durvalumab plus the chemotherapy arm compared to the chemotherapy alone. Next slide. So the two studies, two landmark studies in the approval of immune checkpoint inhibitors along with chemotherapy for the upfront management of extensive stage small cell lung cancer are IM Power 133, where atezolizumab was combined with the chemotherapy, and the other one is a Caspian study, which is a combination of durvalumab with the chemotherapy. Though both the trials have shown similar results in the improvement in overall survival, there are some major differences in the study design. You can see that the Caspian trial is the inclusion criteria used in the Caspian trial was reflective of real-world clinical practice. A Caspian trial allowed treatment with either cisplatin or carboplatin, where the physician has given the choice, the freedom of selecting the type of platinum that can be combined with the durvalumab. And also the Caspian study included patients with either asymptomatic, untreated or treated brain metastasis, and also compared the control arm, compared to a control arm where 6 cycles of chemotherapy was used as an option. And also here one important thing is that the Caspian trial never allowed prophylactic cranial irradiation in the experimental arm. Next slide. So what does it mean? The Caspian trial is a well-designed trial, robust design with the control arm, 4 versus 6 cycles of chemotherapy, 4 cycles of chemotherapy along with immunotherapy of durvalumab, compared with the full 6 cycles of chemotherapy in the control arm. And also the prophylactic cranial irradiation was allowed in the control arm. Next. Not allowed in the experimental arm, and there is a flexibility of selecting the platinum. Next one. Yeah, and shown a significant improvement in overall survival at 24 months, and it's about 22%. Next one. So that shows that the Caspian trial is very well designed, and compared the addition of immunotherapy with the combination of chemotherapy, and it was compared to the conventional chemotherapy and found to have an overall survival advantage of 12.9 months with an impressive hazard ratio of 0.75. And the efficacy is one important point to remember is this efficacy is regardless of brain metastasis. So with this, I feel that the combination of these 2 trials have shown clearly that there is a survival advantage of 12 months compared to the chemotherapy where it is about 8 to 9 months. And that survival advantage is maintained even after 12 months. It's something to really look forward. So coming future, this combination of immunotherapy and the doublet combination of etoposide and platinum or the irinotecan plus platinum will be the gold standard of treatment in extensive stage small cell lung cancer. Over to you, Raj.
Thank you, Dr. Warrier. I mean, for walking us, very lucidly through the Caspian trial, and these are important studies that have really changed the outlook for small cell lung cancers after a long time. Thank you for that lecture, and I will request my another very dear friend, Dr. SVSS Prasad, to chair the next panel discussion, and then to introduce the topic. Dr. Prasad.
Thanks, Dr. Raja. So far, we have had all very good discussions. And to set the platform, Dr. Narayanankutty has just introduced us to the immune checkpoint modulation of the small cell lung cancer treatment. And now I would request Dr. Raja to do the moderation of case-based discussion of the optimal management of extensive stage small cell lung cancer. And I am looking forward to learning from the real world scenario of how much we can put in these immune checkpoint inhibitors to improve on the survival of the 6 to 12 months that we see in the extended stage small cell lung cancer. Over to you, Dr. Raja. I hope you would be able to introduce your panel members.
Yeah, I will. Thank you. Just allow me to.
Meanwhile, I can introduce the panel members also.
Yeah, you can please introduce.
Yeah. The panelists are Dr. Vinayak Muniratnam, Dr. M.S. Vishweshwara, Dr. Anita Ramesh, Dr. Deepak Kopaka, and Dr. Prashant Parmeshwaran.
Raja, so please note, Dr. Deepak and Dr. Vinayak will not be able to join us. Can I request the three esteemed speakers, that is Dr. Mark Vincent, sir, NK Warrior, sir, and Vinayak Maka, sir, to please join the panel?
Ashish, I'll join.
Thank you so much, all of you for joining us, and thank you, Dr. Prasad, for setting the for us. And I also invite Professor Mark Vincent, if you can, sir, please join us for this panel discussion. Quickly moving on, I'm presenting a case which is a 54-year-old male with but had a long smoking history, presents with a facial swelling and dyspnea and cough with blood in the sputum, and that's how he looks. And blood pressures and oxygen saturations are 93%, but has got a neck swelling and purple discoloration of the face, facial plethora, and very prominent neck veins, and you can also see the chest veins. And this is how the X-ray looked. You can see the mediastinal mass, and also you can see the diaphragm, kind of pulled up with a juxtaphrenic peak sign in the diaphragm. So went on to do the next investigation. So I would like to request my panelist, Dr. Vishweshwara.
Yes, sir. I think biopsy. First thing is probably this is a mediastinal mass with SVO, as the clinical features suggest. So we need to go with a CT thorax with the guided biopsy. That would tell us the histology and what is the pathology going on inside the thorax.
Dr. Prasad?
Yeah, I agree. We require an imaging initially, preferably in this SVCO. He will not go for a PET scan. He requires a PET scan for definite, but either CT thorax, a contrast CT thorax, followed by a tissue diagnosis.
So we went on to do a CT scan, and the CT scan showed that there was a large mass with an encasement over the SVC compression, and there were liver lesions, and we staged it as T4N2, M1. Liver is present, and there were some deposits on the left adrenal gland. And we went on to do the bronchoscopy, and the bronchoscopy confirmed that the pathology is small cell lung cancer. The patient happened to be a doctor, and therefore we could go ahead and do the PET CT scan also. And these are the PET CT images. You can see the upper mediastinal mass here, and quite a dramatic presentation. So my question to my panel is, I think Professor Anita Ramesh has also joined us. Dr. Anita Ramesh, if you are there, do you routinely do MRI brain for your extensive stage small cell lung cancer patients, Dr. Anita?
Yes, if I'm doing a PET, it doesn't need, but if I'm just doing a CT scan, like how you did, definitely MRI brain is needed in an extensive stage small cell lung cancer. Okay. Yes, I'm doing.
So Professor Vincent, if you are there, is MRI a compulsory part of standard of care, MRI of the brain, Professor Vincent? And if a PET is done, will that preclude an MRI of the brain? I'm not sure if Professor Vincent is there, so I'll ask you, Dr. Vinayak. So would you leave the MRI if a PET CT is available, Dr. Vinayak?
Sir, I would definitely consider MRI whenever the limited evaluation is done. if PET scan has a good quality of slice, sometimes we don't know what kind of PET scan, CT scan, the technology is there. So if I'm very much assured that that CT scan with contrast also is able to save few metastatic disease there, then I would stop the chase. Otherwise, it will not be so aggressive as compared to limited stage.
Okay. Suppose you do MRI and you do find some lesions in the brain, and if they are asymptomatic, Dr. Prasad, what will be your immediate thought? Would you want to really address the brain, or if the patient is symptomatic, of course, but if the patient is asymptomatic, what will be your thought? Would you think about systemic therapy, or you are worried about your brain lesions?
Ideally, in a small cell lung malignancy, if any brain lesion is there, you have to address. There have been scenarios where we have kept it under follow-up and we have addressed it later. But there is no concept of SRS in a small cell lung cancer. So it's either a whole brain or not a whole brain. So we have to think as of now, if you are using this immunotherapy along with the combination, I think so if they are asymptomatic, you can address it later also. But otherwise, you have to address the brain.
Dr. Visveshwara,
yes, sir. Particularly about this patient, when you have got a SVC and an asymptomatic, if required a brain metastasis, we would go with systemic therapy because the brain metastases are not going to give any problems, rather than the SVC problem causing him respiratory distress. As Dr. Prashant said, we'll wait and see, sir, until after the systemic therapy, we'll re-image and see, and then add up radiation if required.
So this patient has got an SVC. This patient has got a few brain mets and is asymptomatic. Then what do we do with the SVC, Dr. Anita? What would you do with Anita? Are you going to still think about systemic therapy, or SVC is going to hold you for doing something?
No, I actually wanted to bring the discussion a little earlier. Before we proceed everything, now patient, what the picture that you showed was the classical picture of a superior vena cava syndrome. So that as you finish off the biopsy, that has to be addressed on the same day or the next day. I would have done. Yes, definitely. One of the drugs is steroids, one minimum benefit. But yes, it relieves some of the edema. I would have started on steroids, some oxygen supplement, spoken to my pathologist, got a diagnosis, even if a cancer or malignancy is fine. Yes, I would also bring in my radiation oncologist at this point of time, whether they want to give a quick course of radiation and give the first shot of chemotherapy or something to relieve the superior vena cava syndrome. And already you said that we got a diagnosis of small cell lung cancer, maybe a platinum or any single agent just to relieve the SPCO, and then we plan. So that will be one of my very early plans to stabilize him and then jump onto the therapy.
Yeah, Dr. Anita, thank you. You mentioned about bringing in the radiation oncologist. Dr. Vinayak, would you be also keen to bring in your radiation oncologist, or your mind is more set on going systemic?
So as a part of multidisciplinary approach, they will be part of the decision making. One. Two, in this, I'm experienced whatever limited experience I have. So patients who requiring urgent radiation is usually patients who cannot lie down also. Sometimes they've been so distressed. So I cannot have a planning, radiation planning for that reason alone. So I would really concentrate on something like using IV lines in lower limbs, try to have oxygen, steroids, and give one course of, usually I prefer carboplatin for most of those patients, and etoposide. I had used immunotherapy also, but it's very gratifying results. Within 10 days, they become much better. Sometimes we keep them a little longer because they're not ready to go home. So we do see a very, very good sensitivity to the chemotherapy drugs, in at least upfront. So I would involve them, but I think the utility has been very limited.
Okay. So we're coming to that particular question because, if you look at the role of radiation in small cell lung cancer, particularly thoracic radiation, as it evolves, more and more studies are leaving behind the radiation, and radiation to SVC is actually becoming more of a part. So that's I wanted to bring. But Coming back to the choice of therapy, you mentioned about your choice of therapy. I'll ask Dr. Prasad, what will be your systemic therapy choice? You have the SVC, you have the veins issue, and so what will be your choice? Would you be looking at a therapy which will involve some less fluids, and what comes to your mind actually?
So I also agree with the previous speakers that radiation, I don't think so, should come the first in the management of a superior vena cava obstruction in the small cell. So platinum is used. Usually we use carboplatin plus etoposide. 1 or 2 days of etoposide is also okay. That means you take tide him over the crisis, and after that go for the routine regimen of EP or and EC, whatever you are comfortable with. But this carboplatin plus etoposide will be my regimen.
Okay. So then, Dr. Anita, I mean, among the choices given here, if the patient is a little stable, I know what will be your choice if you want to pick these three? How you are going to start planning the therapy for this patient?
Yes, okay. It depends from many issues, depends upon the patient, family, where you are treating, what are the availabilities available. With the three choices that you have highlighted there, it's a very valid choice. Yes, if I'm in the medical college, cisplatin etoposide and carboplatin etoposide will be my only choice, and there we don't discuss about anything else. Now, when I come to my private practice, yes, in the reimbursement sector and the corporate sector, and that's all how I tell people, yes, the choice of atezolizumab and durvalumab comes into the discussion, because both of them, if you see the NCCN guidelines, has approval. Okay, so though the drugs are available in India, both of them has patient assistance program. I will start carbo etoposide as the main chemo backbone and discuss the use of any of these immunotherapy, because we have seen these small cell lung cancer extensive has lots of immunogenic potential, and this is a definite an option and showed benefit with a good response rate in a small cell lung cancer. Yes, immunotherapy is for discussion.
Dr. Visweshwar sir, and if I have to ask you, I mean, what is you are from Mysore, and what is the practical setting?
Here again, I'm in a setup where we do get 30% of corporate patients and 70% of the routine patients. And even now, we have not used in very few patients, except 1 or 2 patients who have not used immunotherapy with chemotherapy. But we are definitely utilizing the carboplatin program. I think it will take some more time for the people also to get accustomed, and the prices also should come down, so that will be available for all of us, our patients, especially in a tier 2 city like Mysore.
Dr. Vinayak, practicality of offering immunotherapy upfront, Dr. Vinayak?
We offer to patients who are reimbursable or who has a financial resource. Basically, it's even with immunotherapy experience, I always have a realistic plan, because end of the day, it's incurable disease. We don't sugarcoat the things for having better survival, but definitely it's a one drug we can really, after 35 years, we got a drug, so we want to use. But most of patients go for the doublet only, and have few patients who have gone for immunotherapy combination. It's a mixed bag for me.
Okay, so let us for the moment assume that we have a good straight-up patient, and they are able to afford immunotherapy. Let's come to that. So that's one of the issue that in our country, affordability. Let's cross that bridge. And then we have a patient who is affording. Then comes the question, with the emerging data we heard from Dr. Warrier, the that is atezolizumab data and the durvalumab data. So how do I start selecting in my mind, Dr. Prasad? You have
both are approved as of now for managing extensive stage small cell. So my selection will be both are okay, but the only thing is that if you look at the brain metastasis or untreated brain metastasis was not included in an atezolizumab. So that is one of the important thing where I'll consider a durvalumab in this group of patients. Otherwise, there has been a criticism about IMvigor that the control arm did only 4 cycles of chemotherapy compared to 6 cycles, and the platinum which has been used. But all that is being secondary. So other than that, there is no difference for me between an atezolizumab and a durvalumab.
So you'll be comfortable with either of it, or that's what you said. Dr. Anita, would you have an algorithm to choose between these two drugs?
Yes, Dr. Raja. Yes, in fact, in Apollo recently, we started one of the patient and we gave the choice of durvalumab and atezolizumab because I couldn't take a decision because both has their demand. Patient attendant chose atezolizumab because it was cheaper. We did talk to the company. I spoke to Arun and whether we can give it. So at this point of time, I think, yes, as per evidence, both the drugs are at same level of approval. I would be happy to give durvalumab, but then there were some hurdles because the cost was little higher than atezolizumab. Patient attended chose atezolizumab. We have started. We are going for the second cycle. So that's the only thing. But definitely durvalumab, what my friend Dr. Narayanankutty presented, this is an extremely amazing data. It's one of the drugs which has come into this type in this malignancy. Yes, I would be love to have this drug for my next patient.
Thank you for being candid about the cost factor, and which is, I think, then I can ask, Dr. Vinayak, there is this advantage of cisplatinum in the data set here. The advantage of control arm, as Prasad said, that having the control arm had 6 cycles of P plus E. And then the most important thing between all of this is probably the inclusion of brain metastasis. So would that matter? That's the question that I want to ask you, Vinayak. Brain metastasis. If brain metastases are present, do you think durvalumab is a better score than atezolizumab?
So coming first to the platinum, sir. I usually carboplatin or cisplatinum, I think it doesn't matter in extensive disease. That's my individual thought. And with cisplatinum, with requiring a lot of steroids for anti-emesis and other things, I'm not very comfortable with using platinum along with IO. 1. 2, coming to the number of cycles, if there is a good response, I would more keen on having RT, some kind of PCI and other things, but rather than increasing cycles more than 6, because usually they get exhausted by the end of 4 cycles. And coming to the brain mets, they're all maps. Actually, all of them are maps. It's food about maps not reaching brain. So I would really take it with a pinch of salt that that drug is better in brain mets and other things. It's just a number play. If you see the numbers of patients who are with the brain mets in the subset analysis, they're less than 10% or close to 10%. I think we're not able to take much of data from that. So that's my input on this.
That's an excellent discussion. Really 10%, that's very, very important. So that was the next question. So does brain met change your treatment preference? So you kind of argued it in one way. Prasad, do you agree or you disagree that brain mets will sway you in one direction or other?
No, with the available evidence, I think so. AstraZeneca has been more strong to have this inclusion criteria for including this brain metastasis, untreated brain metastasis. So I think so. With a brain metastasis patient, the data is more for durvalumab compared to atezolizumab. So there is no science behind that, which I agree, but still.
Yeah, Raja, can I just add one thing?
Yeah, please.
Yeah, see, but if you see your previous slide, there is also something for SBRT. So just wanted opinion from everybody and from your comment also. Why not add SBRT, whether it opens the blood-brain barrier, it also gives you a scopal effect with the immunotherapy. So why can't we have a choice like either atezolizumab, durvalumab, chemo, and radiation, and the role of enhancement of radiation effect when you add immuno and radiation together, just for discussion.
Yeah, sure. Dr. Visveshwara, sir, you have a comment on that?
Yeah. Dr. Anita has rightly said, we can always think about that. And SBRT is one of the options because the technology has been coming up and with reduced toxicities, we can definitely think of it and think that as an option also.
I think
if I can interrupt, Dr. Raja.
Yeah, please.
Just to make matters clear, if you look at the Caspian trial versus the IM33, It's just that they have not included the brain metastasis patient, but they are not saying that in brain metastasis patients, durvalumab is going to be better. That's not the inference, I suppose.
No, in a IMvigor study, the brain metastasis, untreated brain metastasis was excluded. And the brain metastatic people were only less than 8%.
So it only means that they were included in the study, but it doesn't mean that the durvalumab.
Yeah,
that's exactly the point.
Agree.
That's the point.
Agree.
The Caspian study, one of the specialist feature is that untreated patients were asymptomatic patients were allowed, and there is an OAS data that has come out with the brain metastasis, and there is also a hazard ratio presentation. If you look at the hazard ratio for all the the entire Caspian hazard ratio, presence of brain metastasis, even the hazard ratio is left of the unity, and the IM power, the brain metastasis hazard ratio is to the right. So, I mean, I know this is still, an arguable point, but there is data that the durvalumab might contest that in the presence of brain metastasis, it has data and it has got a better hazard ratio, which is not demonstrable in the atezolizumab data so far. So that's the answer to your question. So coming to this, elaborating on that, Dr. Vinayak, what do you think about the overall survival benefit that was updated overall survival benefit with the at the 2-year time point? They didn't have an EFS which was statistically significant, but a 2-year 22% versus 10%. Dr. Vinayak, what is your comment on the OAS outcome?
Sir, it's heartening, sir. To see a plateau of any curve with immunotherapy is very heartening. This is what we are we're doing the things for IO, and 2 years reflect that. But one thing I would look closely is the most of these trials, the rescue, that is a salvage IO is used for most of patients, in almost 13%. So the benefit is around 20 patients, and you have a salvage of almost 13%. So even if you see the other curve also flattened out, so flattened out curve. So I think with the crossover or with salvage thing, I think OS will be very difficult to see. But I agree with you, response duration is very interesting. And we don't need to be convinced. We already are convinced, but it has to be closely seen.
That's right. The special things about the Caspian, one another thing that you present is the duration of response is also statistically significant. The 2-year PFS is statistically significant, and the OAS advantage seems to be statistically significant. And of course, as everybody knows, right now there is approval for both atezolizumab and durvalumab in this setting, and both of them actually have. Durvalumab plus EP has a category 1 recommendation, but again, to be very fair, the atezolizumab has also got a category 1 recommendation. And we talked about the superior ORR rates with the addition of durvalumab. And coming to the question of, I'll ask Dr. Professor Visveswara, what is the role of?
There is a role of PCI in extensive stage SCLC, and also as we discussed earlier, Dr. Anita also has told, there is a role of local RT to the residual primary, because that disease itself is very radiosensitive as well as chemosensitive. Definitely a consolidative radiotherapy or after 3 to 4 cycles of chemotherapy, radiation can be added in between as a sandwich therapy to the local area, local regional area. And PCI definitely has got a role in ES-SCLC also.
Dr. Vinayak, if I may ask you, PCI, everyone agrees, but what do you talk about the local radiation, thoracic radiation, post-year treatment? What is your current thought?
Definitely, there's a role for, if you see the even median PFS with all this immunotherapy, it just reaches around 6 months. So, and it is being proven that patients who have more than PR or CR, definitely there is a benefit of doing a local RT as well as PCI. PCI has a survival advantage, whereas there is some doubt with 2-3 trials whether there is a benefit with local therapy. But personally feeling, I think in a uncurable disease, multimodality has to be there for best survival.
Thank you. I think my time has run out, and I know This was already shown by Dr. Warrier. For these advantages, at this point in time, we have had at least a very exciting new option, durvalumab plus the platinum doublets is a new standard of care in the first line treatment of extensive stage. Absolutely on time. And I then request Dr. Vinayak for to be here for delivering the last lecture, and he's going to give an important update on keynote 604. Dr. Vinayak is a senior consultant medical oncologist from the MS Ramaya Hospital, Bangalore. Dr. Vinayak, please.
Thank you, sir. Kashish, shall I share the screen?
Yes, sir. Please go ahead, sir.
Can you see the screen?
Yes, sir. We can see the screen, sir.
Thank you. So I think I was a little bit taken back when we had a panel, and I'm going to discuss a trial about pembrolizumab. So this keynote 604 is a pembrolizumab with with placebo control with first line extensive small cell lung cancer. This has been already so with the background, I think has already been discussed. We have a small cell lung cancer which accounts for 15% of all the lung cancers. The 5 years OS is less than 10%, and the first line therapy for almost 30 years is chemotherapy. Pembrolizumab has been approved for the later lines, that is third lines, based upon the keynote 028 and 158. And we already have 2 other drugs which have been approved for first line. So with this in context, they have got this keynote 604 study design, which is in patients who are stage 4, who have not received any systemic therapy before the treatment. There was a provision to assess the biomarker, and the data is not available. Patients with no unstable brain mets were used. That means it's been very clearly defined. So any brain targeted therapy should have completed at least 14 days, and patients should not be on any steroids at least 7 days from the study, before the study. So apart from adequate organ function, other things, patient has been stratified for the platinum as well as PS as well as LDH. The drug has been given every 3 weeks. There are 4 cycles were given, followed by maintenance of pembrolizumab for almost to complete 2 years. And this was 1:1 randomization. Statistically, I think the new primary endpoints have been changed. The nominal word is that they have the co-endpoints. So even this trial had a 2 endpoint. One was PFS, and the evaluations were done in a stagger way. The 2 interim analysis was done, and the final assessment was done after the 30 months of the study period. Coming to the baseline characteristic, almost it is equal. We do see a little bit more numbers of brain mets in pembrolizumab, and biomarker wise, it is less than 50%. As of now, the biomarker in small cell lung cancer is not much to be seen, and we see that carboplatin is more preferred over cisplatin. So patients were around 453 patients were randomly allocated to the 2 arms. One thing we have to remember in this curve is that subsequent IO therapies were used for almost 13% of patients, which is similar to most of the studies of the IOs. So the first, the interim analysis where they done PFS analysis, most of the patients had almost equal, 4.5 months, median survival 4.3. The curves were yet to flat out. So roughly around 10% patients were dipping in. So in the final analysis, when they did a PFS analysis, there was 4.8 and 4.3, hazard ratio of 7.3. This study has shown the suppression of the curves, which coming to the almost in 1 year we expect 15 to 5%, and at 1.5 years it is around 10 to 2%. The OS curve is little bit not very divergent curves, but definitely there is a survival difference, and I see that there is a overlapping of the curves, which I am not able to explain it, but definitely there is a median survival benefit is there, and there is a nominal significance of the OS data is there. In patients who are as treated at the final analysis, there is a nominal benefit of this on the OS survival. So coming to this curve, which has been discussed very lot. In this curve, in PFS, except brain mets, most of the study arm favored the IO combination, whereas in OS, it becomes very obvious that the brain mets don't get benefited. And again, the number is around same number, around 50%, where the other studies have shown benefit. So oral response rate is around 70%, and only in the reminding that the chemotherapy is very effective, almost 61% will have response to even to the chemotherapy arms. The duration of response is as similar to other disease. Almost 1 year, we can expect close to 20% of patients still responding who have responded initially. So coming to the adverse effects, that's similar, the toxicity, all causes toxicity, and we have seen neutropenia, anemia, all were seen similarly. And the grade 5 neutropenia, grade 5 adverse effects were seen in 6%, whereas compared to 5.4%. And coming to specific IO toxicities, it was more with pembrolizumab as we expect. Hypothyroidism. We have got little expertise, but they were seen. And discontinuation because of treatment was 5%, close to 6% in IO arm compared to placebo. Coming to the health-related quality of life assessment scores, adding pembrolizumab to chemotherapy did not decrease any of the assessment scores, and it was improved initially in both the arms, and the improvement in the IO combination was more than the placebo control arms. And definitely this supports data of using IO therapy in SCC. To conclude, adding pembrolizumab to first line definitely improves PFS. The OS, I think the significance is missed, but definitely the whatever curves have been shown, there's a durable response in the subset of patients. And coming to the OS thing, it was not powered to the OS as compared to the previous two IO molecules. So to in the context to see what all the things this is working around. So we had another trial where we had ipilimumab in the upfront, which failed in this subset, whereas durvalumab atezolizumab definitely shows much more benefit in terms of having a statistical significance. Otherwise, if numerically if we go, most of data falls around that. Thank you. Thanks for the opportunity from the organizers. I think I'll stop my slides. Any questions? I'll be happy to take it.
Yeah, thanks, Dr. Vinayak. I think I was asked by Dr. Raja to give some concluding remarks, which I do with a lot of pleasure. All in all, we had a very good discussion on lung cancer today. Some of the take-home messages which I could from this meet is that in a stage 3 disease, a single station N2, you can think of surgery. If it is a multiple stage N2, don't think of surgery. Going for concurrent chemoradiation if possible, especially in a good performance status patient. Or you can even do sequential chemo-RT, where the results are pretty much similar, except that 4 to 5% difference in the outcomes. And then we come to the immune checkpoint inhibitors, especially durvalumab in a non-small cell lung CA, adding hugely to the OS as well as PFS benefits as a therapy after completing the chemo-RT. And so durvalumab has definitely found its place. Then comes the discussion in the small cell lung cancer, especially the extensive stage, where again the immune checkpoint inhibitors have found their place. And in the case of brain mets, asymptomatic, you can think of durvalumab as the choice. And if there are no brain mets, you can both atezolizumab as well as durvalumab have both category 1 recommendation, and either of them can be used. In that sense, we are looking at improving the survivals in extensive stage small cell lung cancer. Other things which we have been doing so far are all common points. And so these are the new learning points today. And it was a wonderful discussion, excellent speakers, especially Dr. Mark Vincent has made a sterling presentation. With that, I think we have come to the end of a great discussion and learning today. And I thank AstraZeneca for providing the platform and Dr. Raja for running the whole session thoroughly well. Thank you.
Thank you, sir. Thank you.
Thank you, Dr. Prasad. And thanks to AstraZeneca for putting us together.
Thank you.